welcome to the month of May. So you notice you have microphones in front of you. So these work a little bit different from the ones we had before. So there's a button on the front of it. It looks like a face talking. So when you want to talk, push that. It will turn off by itself when you're not talking. But you can also turn off and the microphone turns right. So there's your instructions. All right, so first let's look at the minutes. I heard it was a great meeting at Lakeview. I was sorry I could not attend. So any comments, or do we have a motion to approve?
I move to approve, and it was a great meeting.
Great. Second, anybody?
Second.
All right, all in favor?
Aye.
We need the delay to be longer on this microphone. It keeps turning off. All right. Minutes are approved. All right, so due to a busy agenda, we don't have the capacity for us to get a liaison update from anyone. I mean, not from anyone, from everyone, I should say. We actually are gonna have the Health Equity Committee presenting today, as well as Public Health Advisory Board. Does anybody who's a liaison have any updates that they're interested, that they feel like there's a big issue? Healthcare Workforce Committee's meeting tomorrow, so I don't really have anything. This thing keeps turning off. Anybody else? John?
Yeah, I just want to recognize the work of the co-chairs of the HPQNC. They're leading there, ending there.
Oh,
And they've done a great job. Just want to recognize Sean and Kristen.
great. All right, Jeremy can't attend, so we have Trilby today. So might say
Jeremy
that's
can't be here because some idiot gave him 2 weeks to go to Paris.
Oh, okay.
I know, why didn't you invite the rest of us?
I know why.
All right, so we have Trilby, welcome.
Thank you.
So we are going to be going to the Yellow Hawk Clinic in the Confederated Tribes in Umatilla in July. And we will be visiting July 1st and 2nd. So I think that's a change of the meeting that we had on the calendar previously. And staff will be getting back to us with details this week or next week. So we're very excited, Rosinda, about coming.
Great, we are too.
So, and I think that moves us to you, Pat.
Great, thank you. A few things to update you on. As I announced last time, Steve Allen has been hired as our behavioral health director. He has now started, and most importantly has come back for his second week. So we're encouraged by that. Unfortunately, we couldn't be here today, so we'll get into the next, I think to the next board meeting to introduce himself to all of you. I know Jeff is going to do a legislative update later in the program, but just a couple of things. Legislative session actually is really going quite well for us, I would say. We've only got 2 or 3 bills that are not mission critical, that appear not to be moving right now. Everything else is kind of on track. Early on, the co-chairs announced that they were going to hold the Oregon Health Plan budget harmless, which is kind of a huge deal. That usually is something that gets decided very late in the session. Now, the bad news is that means all of our policy packages, as we sit right now, technically are dead, and there's a lot of really important stuff in those packages, particularly around behavioral health, but there's a lot of work yet to happen, particularly in terms of the tobacco tax. Basically, a passage of the tobacco tax frees up general fund to be used for other things, and so we think those two things are strongly linked. We've been going through our phase 2 Ways and Means budget presentations, which phase 1 basically is kind of a series of about 12 or 13 overview presentations to the committee on the stuff that we do. Phase 2 are deep dives that they request on specific topics. This week we'll be doing a deep dive on the behavioral health system. Really, and we're going to try something kind of different for us at least, which is instead of having sort of a fairly dry systems descriptive discussion, we're going to go through a series of about 8 case studies and from real people who have really interacted with the behavioral health system, and talk about how those cases went, good, bad, and ugly, to illustrate sort of how systems work, how funds flow, where breakdowns occur, where there are good opportunities, and then really try to tie that to our legislation and to our budget proposals. So that's kind of a little bit of what's going on, and as I say, Jeff will give you a little bit more detail later today. The last thing, just a quick update on CCO 2.0. The final application deadline was the 22nd of April. We had 19 specific proposals. There were a couple of letters of intent that didn't materialize into proposals. By the time that happened, they were kind of anticipated. I think just off the top of my head, there were a couple of pieces of geography that Trillium ultimately did not apply for, and then Providence had a series of kind of one-off applications at its hospitals that were outside the health share umbrella, and they ultimately didn't submit applications on those. So we're now in the midst of the evaluation process. We expect that to go through mid-July. Mid-July is kind of an intentionally obtuse deadline, so that we can make sure thoroughness and completeness rather than an artificial deadline. Ultimately, we'll announce preliminary awards, and I really want to emphasize the notion of preliminary awards. There will be subsequent to that, there will be a readiness review, and that's a meaningful review. So it is entirely foreseeable that someone could get a preliminary award, and then when we really open up the hood and get into the mechanics of how their application will really work and the demonstration of the things that they can do, it's conceivable someone who got a preliminary award may not ultimately get a contract. So those are really 2 very meaningful stages of evaluation. In any case, we continue to be on target to have those contracts in place by the first of the year. I think that's all I've got for just general agency, but if anyone's got questions about anything that's going on, I'd be happy to answer that.
I have a question about the readiness review process and how you'll be engaging community feedback around the applications themselves. Can you speak to that?
Yeah, thanks. We'll actually do that in 2 stages. There will be some community engagement evaluation at the front end, but really it'll be looking for the demonstration of community engagement that's occurred as part of the assembly of the application process. So, and we'll look at things like have there been concerns expressed by communities, or is there a thorough demonstration of support in areas where there's going to be potentially multiple CCOs? What's the community engagement necessary for that to work, particularly across hospital systems and public health authorities and those kinds of things?
And not today, and not now, but it would be nice, I think, if the issues around current cost challenges among the CCOs. I mean, I keep reading that the 3.4% is not where most of the CCOs are at. And I'd personally just like to know more about, so what is the health authority doing? And what's the prognosis for that?
Yeah, we can certainly work on that, both in terms of trends, work that will come out of, assuming Senate Bill 889 passes, and then what we're doing in the rate setting process to get closer to a global budget, so we can put a marker down for all those things. One other thing I should touch on and neglected to, we've been in the news a lot lately around behavioral health, and particularly around the state hospital. And the portion of the state hospital that treats and does restoration services for those who are engaged in the court system and are unable to aid and assist in their own defense. We sometimes call those aid and assist patients. We also call them 370 patients for the chapter of state statute that deals with those folks. We're subject to a Federal Court of Appeals order that people who are remanded to us for restoration under 370 be admitted within 7 days, and we are failing to meet that standard right now. We've done a bunch of things over the last 6 to 8 months to try to address that. Right now, patients on 370 orders make up about 40% of the hospital population, which is a dramatic change from 6 years ago. So it's about 250 to 60 patients today. That's up from not much more than 100 6 or 7 years ago. So it dramatically changes the treatment milieu in the hospital. And right now it's creating a capacity issue. Today we're admitting people in about 21 days. And we've now been in court once and maybe in court a few more times on contempt orders that were not complying with those admission orders. Our argument so far has been that we've massively shifted the operation of the hospital to accommodate more people. We have budget asks for more community-based treatment. We've already received and deployed resources for community-based treatment, so we think we're doing everything that we can, but that's kind of the current discussion that's going on right now. And that's all I have. Yeah.
Is it a change in demand, or is the patient population increase just because we're meeting the needs faster?
It's an increase in demand for sure. And one of the interesting kind of factoids about the whole thing is that we've assessed the current population in the hospital under 370 orders, and 60% of them were homeless at the time that they were arrested. And so the linkage between homelessness and the impacts that has on the ability to treat people's mental illness before it reaches crisis stage and causes law enforcement interaction, I think is really kind of one of the key elements of this. Also, we've talked, I think, here a few times about sort of the increasing acuity of everything everywhere, and that's manifesting itself as well. While 30% of the people on 370 orders were arrested on misdemeanor charges, which is of concern, 70% are arrested on felony charges, and so it's not so easy as to say there are a majority of people who shouldn't be in the hospital or something like that. I think that's part of it, but it's that combination of acuity and homelessness, I think, that's really has made this crisis acute since last summer, really. That's all I got.
All right. So it's my pleasure to welcome back John McConnell, Dr. McConnell. He's going to be presenting today on an overview of healthcare spending. We'd like for the board to hold their questions until the end. We've reserved about 15 to 20 minutes following the presentation for the questions and answers. So welcome.
Thanks, I appreciate the opportunity to be here today. I have to do a little bit of turning and swiveling here, so we'll do our best. So what we're going to cover today is I'm going to walk you through some healthcare spending trends. Some of this will be familiar to you, some may be presented in a different way. Fortunately, we have pretty good data on Oregon. This is new. I think if I tried to do this presentation maybe 5 years ago, we wouldn't have quite as detailed data, and that's helpful to see. Talk about why this matters, then kind of go to what's underlying spending, why does healthcare spending go up, talk about some current policies nationwide that seem to have attracted attention, some of them have had impact, and then tie this into the benchmark. So let's talk about healthcare spending trends. This is sort of looking over time. AWI is average wage index, and so generally as a country or state we get more productive and wages, household income tends to go up. In general, that has outpaced sort of overall prices, and so if you look at a typical basket of goods, wages go up more than that, but not when we look at healthcare. And so this has been a challenge where healthcare spending has been growing at a more rapid pace than overall wage or income. So healthcare spending, this is sort of recent data coming out of CMS, and so they're anticipating that this is going to go up at 5.5% over the next 10 years, or I guess 9 years now. And this is faster than what it has been in the previous 10 years, where we were at 4.5%. And at that trajectory, we're looking at nationally healthcare to account for about 19.4% of GDP. In other words, 1 out of every $5 that we'd be spending as a country would go to healthcare. Why is this spending going up? Well, this report from CMS, the Centers for Medicare and Medicaid Services, their actuaries, they looked at the reasons, and so most of that growth, or at least half of that growth, is because of increases in prices. About 1/3 is use and intensity, and so this is our tendency to invest in things that where we can do more, we treat at lower levels, those types of things. And the rest is demographics, and so we have a population that's becoming older, and we have more people to treat with as they get older. So we're always curious about what's happening in Oregon, and so I've got some good data to show you. This comes from Comagine, which is the old Health Insight, which is the old QCore. And so they've got data here from a variety of states, and so what you're going to see here on the horizontal or sort of vertical axis is if you're up high, you're a high spending state. We can think of spending as being the combination of how much you use and what the price per unit is, and so blue is how much you're using, and green is what's your price. Before I show you Oregon, just to get some idea, so you can see Colorado here uses a lot and the prices are high, and so their overall spending is higher on average relative to the other states. Minnesota is a little bit lower, a little bit higher prices, a little bit higher utilization. Here's the other two states, and here's Oregon. And so what do you see in Oregon? Oregon is sort of average overall spending, high price, low utilization. This is a pattern that you see by service, and so you don't have to look at all the details here, but I'll kind of highlight what it looks like for inpatients. So you see inpatient spending here in terms of resource use, utilization is lower for Oregon, but in terms of overall price is higher, and so the overall inpatient kind of average spending for Oregon is about in the middle of these other 5 states. And that pattern occurs in inpatient spending, but also other spending. And so Oregon kind of generally can be seen as a sort of a high price, low utilization state. So now this is data looking nationally at prices in Oregon, and so there's data, and we could go through hundreds of procedures, but I'm just going to highlight a few. And what you'll see here, these darker states are higher price states, and lighter blue states are lower price states. And as I click through some of these, you'll see that Oregon tends to be on the dark blue side. And so this one is price of childbirth. Oh, sorry, this is primary care visit. So Oregon's quite high. Childbirth, Oregon's pretty high. Emergency department visit, Oregon's pretty high. Here's an MRI, Oregon quite high. And then, of course, heartburn evaluation. I put that in there because this is supposed to give you heartburn based on Oregon's high prices, and so you can see it's quite high to get that assessed too. Okay, so then what about, so Oregon is high price relative to other states. Hopefully you are believing that. So what about price variability within Oregon? These are data from OHA, and so I'm just picking 4 procedures here. These are hospital prices, and so you can see the median price. If we looked at prices coming into hospitals, what they're actually, what insurance plans, commercial insurance plans are actually paying out. So this is the median price of a CABG, which is a open heart surgery, $84,000. And then we can look across the state. What's the 75th percentile and 25th percentile? It gives you some idea of the range. So you see some hospitals at 75th percentile are getting paid quite a bit more than the median, some getting paid quite a bit less, and then the overall ratio of the 75th to 25th percentile gives you some sense of the spread of prices here, so that's CABG. If we look at the other procedures here, you see a lot of variation. And so some variation is probably normal, but some probably suggest a lot of pretty inefficient market, or at least some ability for providers to use their market power to really drive prices up. Whenever I talk about commercial prices, there's always the issue of cost shifting, and so I think that what we do know is that if you look at hospitals or clinics, that there are different prices paid. And that there probably is cross-subsidization, so there probably is some money that's used from commercial prices that subsidize patients who are uninsured. But that is not how we define cost shifting, and so I think it's really important as we think about cost shifting, about the dynamic here. And so cost shifting, when we talk about cost shifting, we mean if we change public prices, do we see a corresponding change in private prices? And so if public payments go down, do we necessarily see private payments go up? And that's the story that we often hear. But this has been an area that's gotten a lot of research, and the best and most recent evidence does not support the existence of cost shifting. The story here is generally that hospitals will do their best to get the best prices they can out of the commercial market. and then they'll sort of do their best around Medicaid, and that there's not sort of a one-for-one relationship there. There might have been that relationship in the early 90s, but now it doesn't look like that exists much. And I think kind of, if we did believe in cost shifting, that lowering prices would automatically make commercial prices go up, we might anticipate that there would be sort of reverse cost shifting when we had Medicaid expansion and we covered a lot of uninsured. And so you can see here that uncompensated care in hospitals in Oregon really took a big dip in 2014 as we covered more of the uninsured. If cost shifting existed, we might think that premiums or prices would have stayed flat or gone down. In fact, between 2014 and 2015, they went up, which suggests that hospitals, they did pretty well, but they continued to use whatever market power they could to get whatever prices they could. So, summarizing Oregon here, so utilization is low. We have low utilization state. Prices look pretty high. A lot of variation across Oregon in terms of prices, and no spending break coming from reductions in the uninsured. So why does this matter? So this matters for a lot of reasons, but it's helpful to think about kind of what is happening to the typical average Oregonian and how does this sort of play out in terms of their own expenses. And so what we see here is that premiums are growing faster than income. So we can start here, we can look at 2010, we can see household income, average household income in Oregon was $51,000. Premiums were $13,756. The cost burden is a measure of how much of the premium, how much is premiums relative to a household. So this is just premium divided by household income. And then just for useful information, we can see the deductible that's left off of this of average deductible $2,000. So that's 2010. What happens if we fast forward in 2016? Well, we see that household income has gone up by 15%. That's good. Unfortunately, premiums went up by 25%. And so the overall cost burden has gone up from 26.8% to 28.9%. Deductibles went up too, and what was surprising to me and interesting in these data was that that nationally, according to these data, Oregon has the third highest deductibles of any other state. So cost burden is high for everybody, but deductibles are quite high in Oregon. So this is important, I think, to sort of understand what does this mean if we have high premiums, because we don't always see them, and sort of they kind of, at least for a lot of us, they're in the paycheck, and we're not sort of immediately aware of that. And I think that sometimes there's even a sense that that this is just something that comes out of employers' profits, and so that employers are paying for that. But the economic theory and evidence for this is that really this is borne by the employee, and so you can think of the employer as offering a compensation package, which is wages, retirement, and health care. And as the health care takes up a bigger part of that pie, that wages get squeezed out. And there's very strong evidence that shows that, for example, in the 2000s when we had health care spending, that wages came up. And as healthcare spending goes up, that tends to squeeze out wages. And so this has a disproportionate impact on low and middle income individuals. So in the absence of cost control, we think that healthcare spending is likely to increase, so that's what the national forecasts look like. We can expect that if that happens, that real wage growth will be slow, flat, or declining. And you can think of this sort of as hidden tax on workers, that this would persist. This isn't something that sort of shows up as an income tax or anything like that, but something that will put downward pressure on wages. And then there'd be continued growth in high deductibles, which appear to be quite high in Oregon. So these are reasons to think carefully about why we would want to have cost control. I want to switch a little bit and talk about why spending goes up, because that's helpful to think about what are good policies around this. And I think that I like to sort of highlight 4 areas. So one is new and costly treatments, and so the issue of new technologies in healthcare is really important. Demographic changes, provider consolidation, and then the market and regulatory environment. So I'll walk through each of these. So new and costly treatments, this is sort of the poster child for this. This is proton beam accelerator facilities. If you don't know what these are these giant things. They cost $100 million to build. They're the size of a football stadium. As I understand it, they're probably useful for a couple of rare cancers that affect the eye and maybe pediatric sort of brain-related types of things. But you can use them for prostate cancer. The evidence is that it's no better than traditional treatment, but you get reimbursed a lot more. And so this is a very high fixed cost technology and facility. Once you build it, the incentives are very strong to run patients through there, and the profits can be quite high. In terms of prostate cancer, this isn't really helping society much, but the incentives are really strong to build these, and you can see that we've been building them like crazy in the US. There's none in Oregon, but this has been going up. What does this mean? This means that we use pretty intensive technology, not for better outcomes, but drives the cost of healthcare up. Vinay Prasad is a professor at OHSU, and he's written a book called Ending Medical Reversal. And this book is not so much about healthcare spending, but about the way we adopt technology. And what happens is that there are lots of drugs and procedures and things that they come out on the market, they get adopted, and then if you kind of watch and then do a randomized trial on them, a lot of times the evidence is not very good. And so medical reversal is a process of finding out after you've released something into the world that it's not evidence-based, and often it does worse than sort of not having it out there, and trying to rein those back in. He's interested in using more randomized trials. That's what his book about, but I think the idea is that we are very liberal in the way that we use technology, new drugs, things like that. We don't really do a good job of reviewing the evidence and whether they're better for patients. We kind of like new things, but they're not always better, and they almost always add to the cost of care. Demographic changes, I'm not going to show any charts there. I think we all know that the population is getting older, and that's going to drive some spending trends. Provider consolidation is another important one, and so this is some idea of what's happening in Oregon. There's been mergers and acquisitions, affiliations, and then provider-insurer partnerships. Kirsten pointed out that the Ascension Providence didn't actually happen, but there's been a lot of other activity. You get some sense that what's been happening in Oregon is what's been happening in the rest of the country, which is a lot of providers coming together. Why do they do that? Well, if you have market power and you're on the provider side, and the insurer side doesn't have a lot of market power, you can get high prices, and so the insurers kind of have to take who comes to them, and providers can use a lot of market power muscle. They can drive prices up. So I think in the previous slide I showed you that there's been consolidation on the provider side in Oregon. What does the insurer side look like? Well, Oregon's insurance market looks to be very competitive, and so this is data from the Kaiser Family Foundation showing that in the large group market, that Oregon's insurance market is in the top decile of being competitive. Number one in terms of competitiveness in the small group insurance market, and 15th in the individual insurance market. We have a lot of insurers in Oregon, and if you go to a state like California, it's 10 times the size of Oregon, but you would find kind of a similar number of insurers. And so the insurers are really working hard. They're very competitive, but facing a lot of market power in Oregon. So insurers in Oregon may have trouble negotiating for lower prices. Final thing I'll add here is sort of the market and regulatory environment that doesn't reward value, and so I think that we've sent kind of as a country, state, at the federal level, employer level, mixed signals to providers about what we really care about. So providers, kind of when I look at what they're doing, they're trying to figure out which foot comes out of which canoe. Should they be focused on value-based payment or on fee-for-service? Fee-for-service was the old world. I think that there's interest in value-based payment, but there have been confusing messages. And value-based payment from a provider standpoint can be quite difficult. So when I look at them having these discussions, there are hundreds of contracts that they have with different insurers. Each of those contracts can apply to different patients. It can apply to total cost of care or a certain bundle. The metrics can be really different. It's hard to manage all of that. It's risky. They're taking on financial risk. They're unclear as to whether patients or employers really care about these things, and they don't really know when they take these things on, how do we address costs? So there's not a clear roadmap on how do you get lower cost if you're a hospital, how do you reduce cost? On the other hand, fee-for-service is a known entity. It's a pretty safe, conservative path. There's lots of experience, institutional knowledge on how to do this. The strategy is just to pursue rate increases and higher volume and admit more patients. Cost is really a minor concern when you're pursuing this. And so you can imagine that providers, maybe they want to do the right thing, but if they're getting mixed signals, there's a strong attraction to the fee-for-service. Value-based payment, you need champions, you need leadership there, but if the signals coming from the federal government or from the state or from employers are kind of mixed on that, you may see on the margin sort of tilting towards fee-for-service. I think that means that alignment and signals really matter. So giving clear signals to providers, value-based payment is here to stay. We're moving this direction. That's what's coming out of CMS. I think that's what's coming out of the Oregon Health Authority. I think they hear that. I think that's where the conversations are. That's where I see the conversations going. Aligning metrics across groups makes things easier for them. I think helping providers do the right thing is the way to look at this, that I think a lot of providers do want to sort of recognize that price is a challenge, but if there's not sort of everybody on the same playing field, the cost of pursuing value-based payments can be quite high relative to pursuing something that's traditional fee-for-service. Here's a good example of alignment, which you probably know about, which is Oregon's Primary Care Transformation Initiative. This is being driven out of the Transformation Center. This is a multi-payer initiative that builds on CPC Plus and some other federal payment models designed to align payment models and metrics across the commercial and Medicaid groups. I think a lot of good work coming out of there, but doesn't not directly address costs. I think more work to do in terms of really tackling costs. So, what does public think about spendings? This is recent data that just out of last month about sort of public's view about the reasons for high healthcare costs. What I want to highlight here is that price is now on the radar. I think this is not so much what people were thinking about a few years ago, but you see pharmacy prices being sort of the number one that's on people's radar, but also insurance, hospital doctor prices, and then some other things that they're concerned about, but people are aware of prices. When you ask them about their view about the best ways to reduce costs, number one is they want to reduce or prevent future disease. But beyond that, I think they're sort of understanding for policies that make it easier to compete on price or quality, or policies that establish limits on charges. I think that sort of, I put those up there, these are the top ones, because I think those are somewhat in simpatico with a cost benchmark. So that's why healthcare spending is going up. What do we see around sort of policies to address healthcare spending? What's working? That could be a long talk here, but a quick review of some things that kind of that give you some roadmap on what's been working. I'll talk a little bit about ACO or CCO type models. These, I think, of things where there's strong incentives to reduce spending. Primary care medical home type initiatives. These are sort of investments in primary care, and then Rhode Island's premium caps. So ACO, CCO type models. So we've got a lot of good data, good research coming out of these. Medicare's biggest ACO model is the Medicare Shared Savings Plan. What are we seeing out of that? Savings after 3 years of about 5% for ACOs that are physician-owned. Hospital-owned, we don't see as much change there, but because they sort of have conflicting incentives about admitting patients. But ACOs where physicians, if they don't admit patients to the hospitals, if they recoup those savings and share the benefits from there, we're seeing some savings there. On a big commercial global budget policy or payment reform was Massachusetts Alternative Quality Contract. I think of this a lot as being a lot like Oregon's CCOs, but a commercial-based global budget, savings of 7% after 4 years, and then in Oregon CCOs, we saw savings of 7% after 2 years. So these are policies where spending was important, there were incentives tied to those, and we saw reductions in spending. We see less changes coming from spending on primary care medical home type initiatives, and so nationally, looking at lots of studies, some meta-analyses, most studies finding no association between primary care, patient-centered medical home implementation and spending, quality, and service use, and this has been a little bit disappointing. There's been a lot of heterogeneity here. A recent CMS payment initiative put a lot of investments into primary care. It's called the Comprehensive Primary Care Initiative. They didn't find any effect on spending, quality, or physician or patient experience. Some disappointment there. Oregon's experience, there was a study by PSU that looked at this, and they found some benefits from Oregon's patient-centered medical home initiative. I think that's good. Whether how you put that in the context of these other studies, I would say pretty strong peer-reviewed evidence that these things don't always work, and so I wouldn't want to put all of the money on just investing in primary care without some other incentives to reduce spending and hope that worked. I think that having incentives or accountability around spending is probably necessary to raise the likelihood that you get reductions in spending. Rhode Island has an interesting policy they put in place in 2010 Results from this study just came in, and so they implemented affordability standards on the commercial market. And so what this looked like was they had price inflation caps on commercial premiums equal to Medicare price index plus 1 percentage point. And then they also forced hospitals to transition from per diem payments, where hospitals were getting paid on how many days the patients were in there, to a value-based payment, looked more like a DRG, or prospective payment there. They had very good results from there. So they saw a spending decrease of 8% after the policy went in place. You can see that the policy went in place here in 2010. Took a couple years to kick in, but then had been sort of flat relative to a variety of other states that they use as comparisons here. So, so good outcomes in Rhode Island. So that brings us to the benchmark. So, so why think about a benchmark? Well, I think I would start by saying that prices matter, but so do these other things: utilization, intensive care, and quality. And the goal is to address overall expenditures. And so I think there's lots of reasons for looking at policies that might address just prices. But I think if you focus on that, then there could be some movement or adjustment on these other areas. And what we really care about at the end of the day is overall healthcare spending. I think there's a variety of lessons or messages or research that suggests that aligning incentives, capping revenues, global budgeting, that those have been effective, that they capture that price and utilization interplay. And the benchmark, I think it gets around all of those, that we're sort of capturing all of the costs there. So what can a benchmark do? It can identify a target, and I think that you could spend a lot of time trying to figure out what the right target is, but I think that's less important, identifying the exact target, than sort of agreeing we're gonna find a target, and that's what we're gonna shoot for. There can be adjustments from that afterwards, but at least knowing what you're heading towards is a starting point. There's a potential of aligning Medicaid and commercial efforts, and so we know that Medicaid is supposed to be shooting for a 3.4% cost growth, and so whether or not we let commercial act independently, or if we're trying to bring that in line, can be part of the conversation. I think it sends a strong signal to providers. I think that there's still confusion on the provider side about how much employers in the commercial market care about these things, and this would be a signal that value-based payments and that cost control is important. And then develops accountability. And so some of the slides that I showed you before showed that Oregon is high price, and that there's a lot of variation across the state. And so right now, in the absence of closer inspection, there's not really an accountability. And so we would expect that hospitals and clinics that have a lot of market power would continue to use that market power. Maybe they feel a little bit bad about it, but nobody's really looking over their shoulder to say, hey, this is not okay, you need to make some adjustments. If these things work, I think that there are a lot of benefits that come from slower spending. It can reduce state expenditures and tax burden, which is always popular. I think potentially increase real wage growth. This one is really important because I think that if we look at sort of who's going to benefit from this, it's not a single party, but it's probably dispersed across millions of Oregonians, and probably has real impacts on their wages, but they don't necessarily have a strong voice for that, and some of that is hidden. And then opens up spending for other needs. And so we're all healthcare people, or most of us are healthcare people in this room, but there's other things we want to spend money on healthcare, and this is a way of opening up some spending on that. Last slide, so just to recap here. So healthcare spending is predicted to go up in the coming years. A lot of that is due to new technologies, higher prices, more utilization. Higher healthcare spending will put a heavy burden on low and middle income individuals. And I think that research is coming out that shows that alignment and benchmarks hold promise as a way of addressing healthcare spending.
Questions?
John? So John, I'm interested in administrative costs. Is there data on what strategies, many of which you've mentioned, are doing in terms of administrative costs? I mean, my own bias is I think fee-for-service is incredibly expensive to administer. Some of that comes from my exposure to EMRs. These are not medical record systems, these are billing systems. And we're spending billions on those systems in order to maximize fee-for-service revenues. Is there any information on the opportunities to significantly reduce administrative expenses?
I don't know if I have a lot to say on that. I know that there was some work done around administrative costs, maybe in the state going back 4 or 5 years ago. Looking around for anybody who can speak to that. Okay, all right, so nobody. I think there was some work done on that. We can go look that up. Beyond that, I mean, I think that's sort of getting things aligned, that's having to track 100 quality measures versus 20 quality measures, that adds to the administrative burden. Lots of different payer systems and contracts adds to the administrative burden. So I think alignment is one way of reducing administrative costs. I think there's more out there. I think people have done some work on that to try to simplify some of the billing that's happening within Oregon, but I'm not up to date on that. So I think it's there. I think there's opportunities for reducing it. I don't know if I have strong policy recommendations for you, sort of sitting right here.
Thanks, Sean. That's great. I often quote the RAND study that says healthcare accounts for 10% of health status, and the rest of it's the rest of the world and our genetics. And also quote Ecologic data that compares what we spend in the U.S. on healthcare to other Western democracies. We spend more, get less. They spend less, get more. But what they don't spend on healthcare, they're spending on social safety net and housing, education, social determinants of health. What the inference is, if we spend more on social determinants, we would need to spend less on healthcare. Has anyone done a calculus as to $1 on social determinants will lead to a certain amount in savings in healthcare?
I don't know if they've done that, but there have been, I think, and you've probably seen this, but Elizabeth Bradley and this team at Yale have done this work that kind of, it's maybe not the kind of the ROI type of thing that you're talking about, but really gives you some idea of how much we're spending relative to other countries. And so that's the most recent things I've seen. I think there's sort of more, there's more and more suggestive evidence that I think makes it look like spending on these social services, whether it's housing or food or transportation, that those look good, but a lot of that really is sort of the devil in the details. I think sort of knowing, just sort of blanket spending on housing doesn't necessarily get you return on investment. It's sort of who's the right population, what's the right terms, those types of things. And so there's evidence coming out to support those types of policies.
Even when Pat started the meeting talking about 60% of people in the state hospital being homeless, that housing led to decompensated mental illness and costs of the criminal justice system. Obviously, we're spending a lot of money in the criminal justice system, a lot of money in the state hospital, and we really need to invest in housing for lower acuity care.
On your consolidation slide, you highlighted some of the increased relationships between insurers and providers, and it strikes me that some of our largest insurers and providers in the state, 2 of them are already integrated and not new relationships between provider and insurer partnerships. And so I'm wondering if you could talk about how the implications of that in our state as we see these increasing relationships between provider and insurer, and that we already have market shares that are significantly dominated by 2 provider insurer companies.
Well, I think what you see in Oregon is what's happening around the country, and so there's been integration that's been both horizontal, which means systems sort of gobbling up other hospitals and sort of creating larger systems, and then vertical integration, which means hospitals employing or gobbling up outpatient clinics and outpatient facilities. And so that's sort of been the trend nationally, and I think lots of good evidence coming out that when that happens, that the main impact is on price. And so I think that that's what we expect in Oregon. I think there's hope that there's economies of scale, and that they'll reduce spending, and that's sort of what often goes up in front of DOJ when you have to do these things for antitrust reasons, but not a lot of evidence ex post that those things reduce cost. Similar story for quality. Hope that by bringing those things together, you'd have systems and improve quality, but ex post research on these doesn't find any benefits in terms of quality. So I think, I don't know if I have any great insights about sort of the specifics between these integrated things in Oregon and the other systems that are coming together, except that I think that nobody wants to be left out. Nobody's comfortable being sort of a one-off hospital or a one-off clinic, or maybe a one-off clinic. I think that there's some more, maybe some benefits that come from autonomy, but a lot of pressure to join systems with the fear that if you don't, that your market share will be even smaller in the future.
What about full-on provider-insurer integration? Kaiser, Providence, what's the evidence there?
Well, it's a question of what do they do? What's their impact on price and cost?
I think I've read some evidence along the way that that kind of integration actually has got some promise and potentially some data to show that it is effective at managing costs.
Yeah, I think there is some of that. I think that kind of going back to when those groups kind of formed or had sort of entered the market, that there were some benefits from that. I think the sort of the incentives are definitely different, especially for a place like Kaiser. So I think that there can be benefits. Yeah, so I think that there can be some benefits from that. I think placing that, how you understand that, or how you place that in sort of the larger context of what does it look like if the market is one Kaiser, one Providence, and then one everybody else. I would expect that configuration would tend to put pressures on prices to go up.
I was telling John beforehand, I'm on the COMAGIN committee for the Total Cost of Care project, and he showed some data from that. That's all commercial. If you look on their website, what they make public is just on their website, and they identify groups by how they performed in terms of total cost and quality. And there's 15 medical groups that are identified as low cost, high quality. 6 of them are in Providence Medical Group. And Providence was one of the 5 insurers who were providing claims, commercial claims, for that. And actually, overall, I think there's 15 Providence Medical Groups. And only 1 is in a high cost group. So suggestive of, well, maybe through that integration, those groups did get the best prices. And that's, a benefit to us. There's not a lot of data, granular data that's publicly available, details. Maybe someday there will be.
Yeah, the other piece of that, another thing I'll add, I didn't show these data, but there's data from OHA on differences in hospital prices. I showed a little bit of that. And if you look, kind of do some work to see which hospitals on average are getting much higher prices and which hospitals are getting lower prices. The lower priced hospitals tend to be in metro areas, suggesting that competition in the metro areas drives prices down, and then the higher ones are in areas where they've got something closer to a monopoly. So I think the Providence, so it's hard to, so I don't have a great answer for this integrated care. I think there's something to be said for the prepaid system, and probably some evidence to support that. I think the teasing out how much of this is integrated care versus kind of competition in urban markets, I think the competition has a pretty strong role there.
Anybody else?
Can I just make one other comment? Go ahead.
So I'm curious as to why Oregon is more expensive than other states, including California. Clearly, I would imagine a lot of the costs are personnel costs, and our wages are probably less expensive than California. John brought up the administrative costs, but what accounts for us being pricier than average?
I would say a competitive insurance market and a consolidated provider market.
I'm sorry, again?
A competitive insurance market,
Mhm.
lots of insurers,
Yeah.
and a fairly consolidated provider market.
I mean, you're almost arguing that the ideal model would be two insurers and two providers that are unrelated to each other.
Yeah, I mean, I think, or I would say a two insurers, nonprofit insurers that would pass their whatever market power they have onto the consumers, and then probably more than two providers, so many providers, so that, you know, if you had the sort of the way you would want to, if your goal is to sort of push prices down as much as you possible, and that's maybe debatable, but, you know, if you have one or two insurers with a lot of market power and then dispersed no market power among providers, that's when you would get the lowest prices. There is other evidence that shows that insurers do these too, and so in places in the country where insurers have market power, they use that market power, and then they don't pass that on in terms of premiums. Premiums are higher.
And with the Massachusetts model, where you're basically just making the costs more transparent and benchmarking, there's not, as I understand, there's not an explicit financial incentive to keep costs low. You're just comparing yourself with your peers. What is the driver? What is the motivation other than status and to keep costs low?
I think that's for you to decide. I think step one is what's happening and how and can we measure it, and step two would be what's accountability. In Massachusetts, it was described to me as, and I think there's I know that there's been some work to understand more about what's happening in Massachusetts by some at OHA. It was described to me as hope, targets, and shame, or targets, hope, and shame. And so you've got a target, and you're sort of making clear this is for real. It's going to be out there. We're going to hope that we get there, and then some shame if you don't do it. And so right now there's no shame, but I think even you know, and this is an empirical question, but we could imagine the difference between a provider and a health plan negotiating in a completely closed door setting versus having a third party being able to look over their shoulder, figuratively. The difference between you know, trying to extract as much possible price increase versus knowing that if it's too much, that maybe it gets in the newspapers, maybe that's sort of the start of accountability, and then I think, you know, if it goes beyond that, I think in Massachusetts, I think there's some potential for the Attorney General to call providers up and ask them to explain what they're doing. So that's, you know, there's some discomfort there. I think that's my understanding of sort of where things are right now.
In our area, transparency has worked pretty well since we're now required to post prices. And particularly with radiological procedures, CT scans, MRIs. And so you have the hospitals and the clinics that are posting their prices, and everybody's looking at everybody's prices. And because we're a small area, it's pretty easy to go someplace else. And it really has created a competitive spirit that I don't think necessarily existed before.
Yeah, I think that's good. I also think that that's sort of, I think the question of accountability is important too, because the transparency can help, but I don't know if it's sort of the end all, and not everybody's going to be a good shopper, and, you know, just sort of using transparency with the hope that the consumers would then be smart enough to shop wisely. I think that's stopping short of actually being able to expect costs to be constrained some.
Hi, thank you. That was a wonderful presentation, and it's so interesting because, you know, I have been working in upstate New York, in Rochester, New York in particular, where the market is so different. Consolidated insurance plans, 2 of them, 80% of the market. Very low prices, but premiums high. So it's exactly as you're describing. I'm just wondering, is there any trending that you're aware of in how competitive the marketplace is for insurers here in Oregon? Is that getting better or worse or staying about the same?
I don't know. Yeah.
I do. It was more competitive at the beginning of the Affordable Care Act implementation. Through those first 2 or 3 rocky years, we lost about half of the carriers in terms of whole number of carriers, not in terms of lives covered. I think there are now 6 carriers remaining, down from about 14 when we first rolled out the individual market. At least in that market segment, and then small group I think is yet a little bit more competitive than that.
John, on the total cost of care data, this is commercial. I think it's important, and want your take on prescription drugs are different here. That Oregon performs well when it comes to prescription drugs. At least these 150 medical groups for commercial do. And I think it's important for us to realize this study suggests there's something interesting going on there. Again, we don't have access publicly to granular data below this to sort that out.
Yeah, that's interesting. And I think, you know, the prescription drugs are a tricky one. I think we can imagine if we engineer things just right, we could probably have a lot to say about inpatient, outpatient, professional. Pharmacy sort of comes in, you know, from outside the state with their own prices. And so I thought, you know, I guess sort of, well, what does that mean for this? I guess the way one framework you could think about here is that right now we say yes, and then every now and then say no. It's easier to say no and then yes. And so if we have a benchmark and we go from there, and then something pops up like Sovaldi, where, you know, this is a really unusual thing and we need to sort of think about that. We can think about, well, what does it mean to let Sovaldi in, and we go from 3.4% to 3.5%, or what do we have to do? But I think that if you want to get your hands around healthcare spending, sort of saying no, and then sort of having a door open of here's a new here's a new price, and that's easier than sort of right now, which is it's sort of a free for all in terms of pharmacy prices. And you know, I think I don't usually say things like this, but they'll charge whatever they can. So finding some way to send signals to them that they'll have to pass through a gateway if they want to sort of find their way into Oregon is maybe one way to look at this.
Would that were easy to do under federal law.
That's your problem.
Thank you.
All right, unless there's any other, oh, Lucinda?
Oh, okay, thank you. I just wanted to say that all of this information is very new to me. I live on the Umatilla Reservation, and there when, you get sick, I mean, you go over to the tribal clinic, and if I'm in urban area, I go down to Chimala. And so when I hear this competition, everybody's competing, I mean, you use Indian Health Service or else Medicaid and sign up for that. And so this is a really learning curve for me about this, because it's really different, you know, when you receive, you know, a lot of your health care from the Indian Health Service, federal government. So I'm learning, and so I think that's good. And then I know it's probably this keeps going off. It'll probably get to us. I mean, a lot of this, you know, that what we're talking about. So I think this is going to be really beneficial that I'll have this, you know, to be able to work from and everything. So I think this is good information, and I'm just really trying to absorb it and knowing that there's a whole lot to it. And so thank you.
Yeah, there's a lot there. So thanks for bearing with me. I know it's a lot of information.
Yeah. Thank you.
Thank you.
All right, thank you.
Thank you.
All right, so we're gonna change up our agenda a little bit. So what we thought we would do is have Toby go ahead. So, and then after she's done, we'll take a break, and then we'll do public testimony.
If you haven't signed up for public testimony, you'd like to give it, please sign up.
Great, thank you. And this is perfect segue, having heard that wonderful presentation. What I'm going to talk to you about is this very colorful piece of paper in your packet that Jeff and I have been working on. Really, Jeff gets the credit for how lovely this looks. And there's logic to the colors and all sorts of things to explain to you. But what this represents is really our effort to put in front of you the work that's going on in the 3 key priority areas for the board. The first being cost and the cost benchmark. The second being children's health. So cost benchmark is blue. Children's health comes next in the green and yellow. And then health equity is reflected in the pink. And then we couldn't resist putting a fourth area on there because we know you all are very interested in tracking CCO 2.0. And so we wanted you to see the approximate timelines for that activity as well. I've just got 10 minutes to go over this with you. So what I'm going to do is talk a little bit about what's going on under healthcare cost benchmark and children's health. But immediately following or after the public comment, you will be hearing from the chairs, the co-chairs of the Health Equity Committee and from Leanne Johnson. So Leanne will be able to talk with you in more detail about what's in the health equity area. So, hopefully this isn't so busy that you have trouble tracking it, but what you can see under the cost benchmark is that the first thing that's going on and where we are right now is really waiting for legislative action on the cost benchmark bill, Senate Bill 889. And then what we're poised to do is really to get busy in a number of areas if that bill does pass. We want to be ready to hit the ground running. So what we've already begun is some stakeholder engagement. And we've also engaged with a consultant who is working with us to really think about what it will take to have the implementation committee move smoothly through considering the different program components that we need to reach consensus on in order to actually stand up the program. We're also beginning to think about some baseline data analysis and what we might want to look at in our all payer, all claims database to get an idea of what our cost drivers are currently. Then how that data is going to be complemented by the new data that would come in under the benchmark program. The implementation committee, those members would be appointed by the governor, and so that will take some time to accomplish, but we anticipate that we'd have the benchmark committee actually starting to meet in the fall, September or October, and they would finish their work. It depends on exactly what we land on with the consultant in terms of how many months of meetings would be involved. We've actually been told that Delaware did it in 6 months. We had anticipated more like 12 months, so probably somewhere in that range. And then come back to the board with the findings from that implementation committee. It would be up to the board to take action on those recommendations before there could be any further activity on beginning to stand up a program. So you see all those things laid out here in their approximate times. This visual really represents for you a snapshot as to what we think the pacing will be of this work at this point in time. And what we intend to do is come back to you every meeting with an updated visual so you can see if anything's changed markedly. Does that make sense pretty much? So looking at children quickly, exciting opportunity in this first yellow box that you see there, the INC grant application. And I just wanted to flag that for you all. This is an opportunity that we've jumped on. It may well help make up for the fact that some of the policy packages that Pat mentioned may not be funded fully. And one of those was the Office for Children's Health. But the INC grant really provides an opportunity to fund a lot of the same kind of activity that we had hoped to do under that office. This would be a chance to work with our children's health complexity data and really use it to begin to stratify risk in a couple of different geographic areas, and then think about how that data might inform local conversation about care coordination, some social determinant of health type interventions, to really improve outcomes for kids. And the metrics for that grant are really about out-of-home placements, so foster care, inpatient placements. These grants, though, will only be 8 across the country, but Oregon is actually very well positioned, very competitive here in the work that we've already got going and the level of collaboration. We're working with our partners at OHSU, the partnership, the Pediatric Improvement Partnership, PIP. OPIP, thank you. Which is already a large umbrella, a lot of groups working together. So if we were to get one of those grants, that's $16 million, up to $16 million over a 7-year period. So that would fund a lot of exciting work. You'll see that there are other work boxes here providing support around the children's health complexity construct with stakeholders. We will definitely be engaging in that work regardless, particularly with the CCOs. And then depending on what we learn, what the engagement is with those practices, we'll be able to spread examples of success in using that data to really target interventions within communities. There's going to be work on the kindergarten readiness metrics. You can see that in the darker green, and that's really being phased in 3 chunks of work. And then the lighter green, convening subcommittees around SHIP priorities will also be taking place. So as you can see, the children's work really spans a lot of different activity in OHA. One last thing I want to draw your attention to, jumping down a little bit in this visual to where you see the state health improvement plan showing up under CCO 2.0, and it's kind of got rainbow colors around it. That is a change since we distributed these materials to you, and that's our effort to really highlight how SHIP is taking place, the alignment with those priorities and the convenings with the community around those priorities is really informing our work in all of these priority areas. That's why it has rainbow colors around it. And you just saw the example of how that becomes a main activity up in the children's area. And you'll see the same happening in the area of health equity, where the SHIP work is going to be closely integrated. You'll see within the health equity area also the ongoing work on Real D, the work on defining health equity. I think you'll hear more about that from the co-chairs today. And some of this ongoing work engaging communities and providing technical assistance, those are areas that we added since you got your materials, things that the Office of Equity and Inclusion is highlighting as being critical aspects of the work that they're going to be engaged in. But again, you'll hear more about that from Leanne. You heard a little bit from Pat about all these deadlines and activities under CCO 2.0. So I think I will stop here with walking you through the visual. Happy to take questions.
I just want to comment, this is the most incredible and terrifying Gantt chart I've seen in my life. Thank you.
Well, I should say we're very open to feedback. If you find it too busy, if there are things you'd like to see differently, please grab me on the break or whatever, because this is a work in progress. And my mic stayed on the whole time. That is weird.
What is this report on waste?
Oh, yes, thank you for highlighting that one. So it has dashes around it too, which means that we don't have any firm timeline on it yet. But that is a project. The Oregon Health Leadership Council has expressed a desire to move forward and engage in some work where we could use a waste calculator. And this is Millman has developed this and used it very effectively in Washington State to take a look at areas of spending that could be defined as waste. We have engaged Millman working with our All Payer, All Claims database, and so we're talking with them about what it might cost to have a similar data run done here in Oregon, and we're talking with OHLC about the possibility of together co-producing a report similar to what Washington put out. The Washington report is called First Do No Harm, and it really generated a lot of interest, a lot of good conversation about that area of spending.
We need to be sure that links up with the same or similar work that Optimus is doing on the rate setting process, where they're looking at outliers in terms of potentially wasteful spending and how to deal with that in CCO rates.
Yeah.
Any other comments? Yes.
In the children's health area, how much of the, I mean, it's great that we're doing some work to address immediate health needs of children, but this in particular, in all areas, but this area in particular feels like, how do we get ahead? How do we use this goal to get ahead and not spend just the immediate health needs, but the contributing factors, social factors and economic factors that go into children's health? And so I'm curious about how, is there also focus on that and to what extent that's being prioritized?
Thank you. Yeah, that's a great question. And I think the children's health complexity data is an effort to get at exactly what you're raising. Because what that data does is crosswalk health complexity with social complexity. And so you find that there are kids for whom the health complexity may not be as high, but the social complexity is much higher. And so what you develop there is a need for interventions that are really taking into account social needs. And there can be populations locally where quite a few kids fall into that category, and yet when you look at the spending, we've really reserved it for that high medical complexity, even when the social needs are not as complex. And we know that the trajectory for the kids with the social complexity may be to move into that high spending on health if we don't address the social complexity. So the idea is to take that data and really work with it on a local and community level to see if it can help guide spending in the direction that you're suggesting.
I mean, maybe hopefully the kindergarten readiness screening will be a surveillance system to pick up the social complexity.
Yeah, I think that's exactly right.
And I don't need to tell anybody this, but I think part of the challenge when we're dealing with this issue is that unless you look at the whole family situation, because sometimes we can help the child out, but if we can't help the family out, then you're not really addressing the long-term needs. And that becomes the challenge with us, you know, if you have the child on the Oregon Health Plan but not the parents, for whatever reason, your resources become very limited with what you can do. And you just have to hope that sometimes your resources will go ahead and address family issues even though they're not, quote, getting paid for it.
And I should mention that I think next month, is that right, Joe? You will be hearing again about the children's health area, in particular about the children's health complexity data.
Yes.
Yes.
John?
So on the healthcare cost benchmark, that's across Medicare, Medicaid, commercial. So is there going to be anything in the bill this year that would encourage or require all the players to cooperate in terms of providing data? Like, will that waste analysis be done on self-insured employers who I think are the holdouts? Or, you know, in the co-imagine work, I think Kaiser's now coming on, but Kaiser has not been in the all payers claim database. And, you know, for this to work, I think everybody needs to play ball in terms of information.
So we still can't compel self-insured employers to provide data. However, I think there are some big data ways to get at some of those analysis questions that don't necessarily require, it would be better if we could, but there may be some potential workarounds, at least at the margins, on some of that, but we continue to be preempted.
I just want to get some feedback. I really love the visual, and as we define it over time, I'm looking forward to more specificity where the board has approval action items or really more specific milestones or deadlines.
Sure.
Great.
All right, so I think what we'll do is we'll go ahead and take a break until 9:50. Once again, if you want to sign up for public testimony, the sheet is over there. I'm pointing to my right. My husband says I point and don't use my words. So. And then after public testimony, then we will hear from the Health Equity Committee. So, thank you.
It took me a long time when we were first married to figure out that my wife turn left this way or turn left that way. this spending that you're doing here is waste, it's not gonna let you build it into rates going forward, and so it dances right to the edge of actuarial soundness. Because if we didn't have actuarial soundness, we would basically say, all right, look, we know that 30% of the spending is waste, so you don't get it, you can find it out of the waste and do it the way they always turn out. Can't do that, so this tries to actually quantify that and basically cut it out. Yeah, you've got to do something like that. Just don't have more.
All right, so we received one public comment through email. I am going to read this. It's addressed to me. Dear Carla McKelvey, I'm writing to you for public comment at your upcoming board meeting about our experience with the Oregon Health Plan Open Card. We have 2 sons on the OHP Open Card, both of whom have development disability. We have Open Card since we also have private insurance. We are grateful to receive the additional assistance and generally have been happy with OHP Open Card. However, recently we struggled with accessing care and were daunted by the obstacles we discovered. This last week, my younger son needed urgent care. I took him to an urgent care clinic that is part of both CCO networks in my area, Jackson Care Connect and All Care. I was told they do not accept OHP Open Card and told I need to sign a waiver agreeing to this. Given this and the expected wait, we took him to another urgent care center which had much longer wait times, and after a 3 to 4 hour wait, he finally received care. He then needed to be referred to a specialist. Unfortunately, since there is no available online care coordination for Open Card, i.e. provider list, we don't know if the specialist selected accepts Open Card. I spent almost an hour on hold for the customer service line for OHP to inquire about what doctors and urgent care centers in our area accept Open Card, but then was disconnected when the representative came online. We feel fortunate that we have private insurance since both our children have development disabilities and are fortunate that we can try to utilize OHP Open Card as well for their care. Finding care providers that accept Open Card is tricky though, since there is not an easy to access online provider list and no easy to access call center. We are concerned other families may also be experiencing delays in getting care. Given that many other families whose children have development disability also have private insurance, we are concerned many others may be having difficulty in using Open Card and wonder if something can be done to help. Care should be readily available to all people, including those with development disabilities and who also happen to have private insurance. Please consider changes to the system that prevent providers from not accepting Open Card when they are part of the CCO network. Also consider providing an easy to access provider list for Open Card participants. Additionally, allowing those with Open Card and third-party private insurance to switch to a CCO, which would be a significant benefit and would allow easy access to the community, something that is often needed for those with development disability. Thank you, Connie Clarkstrom. And my understanding staff is already taking a look at this. So, thank you.
Is there an omnibus person for like this or concern like this?
Yes, we have a ombudsperson, and in fact have significantly expanded that resource. We're in the midst of hiring 6 more ombudspeople to join the one that we currently have.
Carl? Yeah, this strikes me as an example, though, if we, 98% of children are covered. Maybe for children, it's time to say, from an eligibility and care, just stop all of this kind of stuff. Now, all children should just get taken care of, and it's kind of like a coordination of benefits issue for insurance. They're all covered. Take care of them, do what it's the right thing to do, and then just sort out who's going to pay, rather than putting people through this kind of stuff.
Just if I could make a couple of comments. First, to the larger issue of fee-for-service, I think this is something we've been talking about or now beginning to work on in the agency, that I think there was sort of a mental model that was never completely accurate, but it was sort of this notion of, well, now that we have CCOs, everybody's going to be in a CCO and fee-for-service will go away. Well, we have 150,000 or so people, about 15% of the enrollment, that are on fee-for-service that will always be on fee-for-service. There's some churn through that population and those kinds of things, but one way of looking at it is that fee-for-service is our 3rd largest CCO. And we're really beginning to grapple with what does that mean and how do you manage that so that we're providing for the people who either have a legal right to be entitled to or for other reasons need fee-for-service coverage, that we're providing meaningful coverage. The coordination of care point you raised is an interesting one. Some of the complexity that you get into that are things like value-based payment arrangements, all right? And how do you structure things sort of on a we the payer and you the provider have a relationship on how we're going to do this versus y'all come and we'll figure out the money later part. So not to say that we can't do it that way, but it's more complex than probably meets the eye.
Oh, well, I agree, but at some point, I think it would reduce costs if we didn't have these kinds of things bouncing around in the system for both providers and patients.
Okay, so Health Equity Committee. Rosinda, did you want to do an introduction of the co-chairs or this item?
Okay, thank you. Yes, today we have with us the two co-chairs of the Health Committee, and also Ms. Johnson is here from OHA, the Health Committee, Health Committee, the chair, not the chair. What do they call staff? Director. Okay, and we have Michael Anderson here, he's in the center there, and then we have Carly Hood-Romick, she's the other co-chair, so that's, I'll let them go ahead from there. Thank you.
Leanne?
The face, okay, yeah, the face with the sound coming out of the mouth, that makes sense, okay. Oh, good morning, it is a pleasure to be here. My name is Leanne Johnson, I'm the Director of the Equity and Inclusion Division for the Oregon Health Authority, and looking forward to hearing from our Health Equity chairs, and I just want to say that these two chairs are continuing on for another year, which we're very pleased about, and have dedicated an incredible amount of their time over and above their real jobs and their real lives, and so we really appreciate the commitment to this work and their leadership of the committee. So thank you, Carly and Michael. We'll turn it over to you in a moment. I just wanted to provide a little bit of context and also ring true to Truly's promise of going over some of the work plan. So we'll start with the work plan, and what we've done here is basically just in terms of the language used and the strategies and initiatives that are represented here. This is the work we are doing as the Equity and Inclusion Division, the Office of Equity and Inclusion in the Oregon Health Authority on behalf of the people of the state of Oregon, on behalf of health equity and addressing health inequities. So we've just rolled up all of the work that we do, and just to tell you about what that means when we talk about all of the work. The Equity and Inclusion Division, also known as the Office of Equity and Inclusion, we carry out about 18 discrete functions in the health equity arena and diversity and inclusion arena for the Oregon Health Authority and for the state of Oregon, and most importantly for the people of Oregon. And 9 of those functions, 9 of them are actually federally or state mandated. So we have there's a great deal of breadth and depth to our work, and we also manage 6 statewide advisory committees on health equity. So the work is very much statewide and community-based. When we turn to the chart, what I wanted to point out, as I've already said, this represents our current work, and really the way I think about this is the 3 longer bars that go across the bottom of the health equity area. That's really our foundational work, and that's where you'll see when I talk about the 18 functions and the 9 that are federally or state mandated. Those fit in those foundational places. And then when you add to that within the other area regarding CCO 2.0, we're working very closely now with the core committee for the SHIP development, and as you know, also along with the Health Equity Committee, have very, very diligently and closely around CCO 2.0 work and policy development that has occurred over the last year. So when you take all the work that we do, it fits really nicely into that foundational work and into the CCO 2.0 and SHIP work. And then what I will add to that is to say that when you look then above those 3 foundational lines with above the engaging communities.
You're talking about this chart, right?
Yes, I'm talking about that chart, yes. When we go to above the engaging, I'm sorry, I don't know what's behind me, so I apologize. Above the engaging communities bar, these areas above that really represent current initiatives that are reflective of the foundational strategies. And so from that perspective, when we look at those areas, some of the areas that we're really focused on from an initiative perspective right now include the Real D collection quality improvement, and then also the health equity measurement work that's going on. So those are two primary current initiatives, and then adding to that the work around defining health equity that the Health Equity Committee is doing, and then that flows into the broader work that you'll be hearing about that from Michael and Carly regarding the work that's being done by the Health Equity Committee. So I'm trying to kind of make sense of, help to make sense of what's demonstrated here on the chart, how that relates to health equity work, and how that represents the broader work of the Equity and Inclusion Division. And I will finally close by saying that our work has been around since 1993, and we actually, looking at building, we grow out of the minority health tradition in public health. And about 10 years ago, the Oregon Health Authority, that was OHA-DHS at that time, made a determination that that work would pull out of public health and be across the entire agency and across the state. So that's just a little history lesson and how we arrived today and what we're focused on today. I will either take questions or turn it over to Carly and Michael, whichever makes the most sense. And from this vantage point, I don't know what makes the most sense to you at this point in time. So please advise me on what you'd like to do.
Why don't we go ahead and move on to your.
All right. Thank you. I'll turn it over to our Health Equity Committee chairs.
Great. Thanks, Leanne. Making sure the slides are up. So good morning. We're excited to be here. My name is Carly Hedronic. I am one of the co-chairs for the Health Equity Committee. In my day job, as Leanne said, I'm the Senior Manager of Health Equity at the Oregon Primary Care Association. And Michael and I are here today just to share a little bit of an update on the work that we've done over the last year and engage in a little bit of dialogue around our collective priorities in this area. Great, it works. So just in terms of an agenda, it'll be fairly brief, but we're going to look back at the last 12 to 15 months and kind of showcase some of the work that we've done. We'll look forward to our next year's plans and provide some context there. It's now been referenced a number of times that we've been working on a definition for health equity, so we will provide a draft of that in addition to some context around how we developed that. And then finally touch on some of the barriers we've hit and potential threats going forward before opening up for questions and dialogue.
All right. So thank you. Well, hello, I'm Michael Anderson-Mathy, and I'm the other co-chair for the Health Equity Committee. And in my other day job, I'm the Chief Equity and Engagement Officer for Health Share of Oregon. So I'm going to be going through our 2018 accomplishments as well as some of our 2019 priorities. We have organized this in 3 slides, and we have categorized things under the 3 distinct tasks that the OHPB have assigned to us in our chart. So when we look at the top slide, that's kind of what you directed us to do, and then we're going to respond with here's what we've done, here's what we're working on. So for the first task in our charter was to provide analysis, guidance, and recommendations to OHPB on policy, including key legislation, specifically using an equity lens. So, our committee was stood up at the very end of 2017. So in 2018, we were really kind of doing some of our foundational elements, and we found ourselves kind of neck deep in CCO 2.0. I think that was all we talked about at almost every meeting was CCO 2.0. In particular, we delved pretty deeply in the behavioral health and the social determinants of health sections of that, and had presentations from staff from OHA and gave lots of feedback, robust feedback as a committee. We also reviewed and supported OEI's equity impact assessment of the policy options around CCO 2.0 and provided some comments to OHPB on that in support of that. We also did our own kind of equity lens review of, I think, all, was it 50-some policy options in CCO 2.0 and provided input to you all on those. And then in addition to CCO 2.0, we've also had some presentations and updates from OHA staff around the 2019 legislative priorities and continue to get updates via our work on the committee. In terms of 2019, some of the work that we really want to do as a committee is we really want to look at how our committee can support the implementation of CCO 2.0, so moving from policy to practice. We're really not sure yet what that could look like and what the kind of boundaries are of that, but we'd really like to be key players in how we translate from a contract into accountability for CCO 2.0, especially around things like health equity plans or some of the training requirements that are in it to make sure that it's in alignment with the committee's vision. We also are going to continue to further refine our work. So we have a policy work group on our Health Equity Committee, and one of the things that they want to do is to develop more of a streamlined process to ensure policy actions come through the Health Equity Committee in a timely manner to ensure that we can really meet your requests for applying an equity lens and giving you solid advice around those. So that's the work there. Okay, great. The second task in our charter is to provide assessment and actionable recommendations to OHA's progress towards achieving defined health equity goals, including becoming a more culturally responsive organization. So for us, we really kind of took this to be how are we helping OHA look internal and really kind of lay some of those foundational elements in place for success around achieving health equity and moving towards a more culturally responsible organization. So, 2018 for us, again, I mentioned we were still busy standing up our Health Equity Committee, and in lots of ways we decided to use it as kind of a case study for really figuring out how we could develop and pilot a committee structure, bylaws, and practices that would elevate equity and utilize more trauma-informed meeting practices in order to both recruit and retain diverse members onto these committees. So the work that we've done in 2018 for our committee, we're hoping will serve as a foundation for developing some best practices to share with the rest of the OHPB committees so that we can really kind of ensure robust, diverse representation in all areas. So part of that in 2018 is to really refine some of that work that we did and figure out mechanisms to share that across the committees. As it's been mentioned, I think, twice now, we have also heard a clear ask for a definition for health equity so that we can have some consistency and standardization around how we use health equity and how we work towards achieving equity, including how we measure our progress. And so our committee has done some work there, and Carly is going to really delve into that and talk about that process. And then the other area where we're really looking to dig into is really figuring out how we as a community can help OHA assess and advise on your progress towards the health equity goals. So I think this for us is really looking at kind of what is the current work being done, what are the goals in place, how do you measure and assess those, how are you accountable, looking at how the ship fits into that. And so that's some of the work that we want to really kind of delve in and understand and figure out then how best to support. The third task, and last slide that I think I'm going to do here, is around collaboratively working with other OHPB committees and help make recommendations to OHPB. So this is the third piece in our charter. So in 2018, one of the goals was for us to start connecting and build some relationships with other OHPB committees. I know OHA staff convened all of us in a day-long meeting. We participated in that and started to build some relationships. We've also lent a lot of support and actively participated in the health equity measurement work group that I think is actively proposing something right now and will continue moving forward. We also had a member who supported the healthcare workforce committee, and so as we've had requests from specific committees, we have tried to assist them as possible. Moving forward, again, like I mentioned before, we really want to kind of spread those best practices for member recruitment retention to the other committees. We'll continue to participate in OHPB committee summits as they are convened by staff. We'll continue to work around the health equity measurement work group as we figure out how to implement kind of our short-term goal and then look to the future around the longer-term goal to measure outcomes around health equity. We, over the next probably 6 months, we as co-chairs are hoping to engage the other co-chairs of the other OHPB committees to really kind of assess what are their goals around infusing equity into their work and how might we best support them as a committee so that we can start to build out that kind of support. Carly, you're taking over?
Yep, so without further ado, we will share a draft definition for health equity that we've been working on as a committee and with support from OEI staff. We've spent some time combing the literature, other related bodies of work in an effort to really provide a standardized definition, as Michael said. So this has been built on existing definitions from the World Health Organization, Robert Wood Johnson Foundation, as well as our local efforts, the Public Health Advisory Board and Medicaid Advisory Committee's efforts to define equity as well. We really wanted to lift up and call out that the values that went into developing this definition are really centered on an attempt to honor the work that's come before us and not recreate a wheel or try to start from scratch. We wanted to apply a strengths-based approach and acknowledge our current and historical context and state in setting this definition, and then engage and value community input. So while not final, and I'll talk through the process in a moment, we do really want to share this and get feedback so that it's something that the community is really engaged in and lifts up with us. So our draft definition reads as, health equity exists when all people can reach their full health potential and are not disadvantaged from attaining it because of their race, ethnicity, language, social and economic status, social class, religion, age, disability, gender identity, sexual orientation, or other socially determined circumstances. Achieving health equity requires ongoing collaboration of all sectors to address both the equitable distribution and redistribution of resources and powers, and recognizing and rectifying historical and contemporary injustices. So our process in developing this is first that OEI shares and some of the committee members share with outlets that they have to engage community and provide input and feedback on the definition. The HEC will then finalize it and share back to put forward to OHB and OHPB and OHA as early as this summer. So there will be time to come back to this in a moment. I'll just wrap up briefly with our sort of barriers and strengths and forward focus as we move into our next year. So our greatest barriers to this work thus far have been the following. First, health equity work takes time. I think in our culture and our society, we've referenced a couple of times today that we want to see results quickly. And this is a body of work that really requires intention, trust, and relationship building. Second, we've been really balancing capacity building, lifting up a new committee, which is admittedly slow, with action. And Michael referenced CCO 2.0 kind of being front and center last year. I would say the health equity metric development is front and center this year, so we're walking that fine line between trying to lift up and create a strong and engaged committee that feels relationally engaged with some of these priorities that we want to engage in as a committee as well. And that balance is not always easy. So moving forward, we really want to focus on retaining a full and engaged set of committee members. We've had a little bit of turnover with folks changing jobs, maybe not recognizing the work that is sometimes required in volunteer committee work. We want to clarify the roles for the committee and OEI staff. So while we have kind of the same golden star, it's not always easy to determine what's staff's role, what's our role as an advisory body, so really kind of teasing that apart. And then third, we want to, as Michael mentioned, proactively engage other OHPB committees and explore ways to interact in the existing structures as well as create new opportunities for supporting those committees. And finally, just utilize the skills and resources that we have on this wonderful committee and with a really incredibly supportive staff. So with that, given what we've shared, I believe there's time for questions and discussion. We've shared a few questions that we have on the slide here. We don't have to focus on these, but they were prompts that we offer in case there aren't questions.
Thoughts, comments?
Thank you for the presentation and the important work. I, as someone who's worked for 20 years in migrant seasonal farm worker health, I find my own impatience, right? So I may be on that criteria of barriers of wanting more progress sooner and recognizing the balance between what is helping create different belief systems that then will kind of transport to new behaviors. I'm curious how you're thinking as a committee about pace about what has been sort of delayed maintenance in terms of conversations or the structures that we're currently working with them, and how you're thinking about work plan alignment and this anxiousness that you're describing as a parent.
Hi, thanks for the question. That is a huge challenge I think we face in equity work everywhere. I think our thinking has been we should have a bias towards action, right? Because people have been waiting a long time and people are actively being harmed by some of the systems that we're trying to change. So we need to have a bias towards action. At the same time, we don't want to recreate the same problems by using the same kind of systems, thought, approach, the same power dynamics and players, right? Like we need to do something differently in order to achieve a different result. And so, it really is trying to strike that balance between making sure that we have a bias towards action and that we're constantly moving forward, and at the same time making sure that we're doing things in a different way to get to our goals. I don't think there's a magic solution. I think we have to sometimes make hard choices around what we can and can't do, given our capacity. And I think we've tried to do that this last year, and hopefully we've been successful in that.
I'll just add, I tend to have a bias towards action and feel that hitting me in the face in a lot of different directions. But I guess I would say one area, in particular, one concrete area I think we've been focused on is really trying to create clear processes for engaging the committee so that we aren't co-chairs or there are new people filtering in and out, there's a consistent process and knowledge of what the committee should be engaged in. And that takes a lot of time and kind of undoing the way things that have potentially been done or creating new spaces. But I think that in the long run will help us go faster.
And if I could also add, is that I think from the vantage point of doing this work from perspective of an OHA employee, I think that, and Pat and I have had some very good conversations about pace, because there are some wonderful ideas and things that we know need to happen, and at the same time we're balancing pushing the system and working within the system. So if the system gets pushed too hard, it rebels. It pushes back harder, and we end up maybe 5 steps back where we could have been 1 step forward. So there's that constant strategic navigation that we are working within and working around. And just to give you an example, for the definition that's being brought forward today, or that you read today, that definition we wouldn't have had traction for this several years ago, just because of some of the resistance in the system. So I think it's important to note that, and I said this the other day in something I was writing, that that there's this whole adage of the square peg and round hole, and you're trying to fit it in. And in this situation, if you try to push too hard, it is repelled, and it can be cast even further away from action. So that's the constant strategic conversation we're having. And then also, I think, how do we define action? So for example, thus far in session, our OHA team of roughly 20 people, we have reviewed 100 pieces of legislation for a health equity lens. So those policies, while they don't feel like day-to-day action, are policies that have a tremendous impact, or can have a tremendous impact on the people of Oregon. So how we define action is also, I think, part of that conversation as well.
I just thought we'll offer a concrete strategy to address that I think we've used at our committee, and that's kind of the yes and approach, right? And I think as a concrete example, with some of the deadlines with CCO 2.0, it wasn't necessarily an ideal process for us to really engage the way we wanted to. And we recognized the importance, right, of having a bias towards action and what was in front of us and why the deadlines were what they were. And so, using that yes, like we're going to do this, and in the future, let's figure out a way so that we can change how the timeline goes or how people are engaged. So it's both, right? It's that both and or yes and approach. And I think that has also been helpful for us getting our work done.
It's interesting, I'm finding myself thinking of Newton's laws in this discussion. You've just talked about for every action there's an equal and opposite reaction. But the other one I'm thinking about is a body at rest tends to stay at rest, and a body in motion tends to stay in motion. And part of how we think about balancing this bias for action and those kinds of things is my profound sense is this body is now beginning to be in motion and wanting to really think about how to take advantage of that beginning to be in motion to be able to continue it and feed it and accelerate it and those kinds of things. And at that end, then just sort of the demands that are increasingly on us to do something now, kinds of things. So this is going to be, I think, a sort of an ongoing tension of how to really think through that, how to feed our biases for action where they exist and do it in a way that really helps the system be better.
So I'm the liaison to the Workforce Committee, and Maria attends our meetings, and she is incredibly valuable. I guess one of the questions I have, and I don't know if this addresses the second question that you have up there, is are you feeling like there's barriers to have a member like Maria on the other committees?
Well, I guess I would say two things. One, maybe not barriers, but it feels like new territory in terms of how we, as committees, learn to interact and work together. And so forging those paths is new, which maybe in and of itself is slightly a barrier, but I think just requires more innovation. I will say Maria is not, we're talking specifically about how the committee members engage with the other committees and Maria's staff. Well, I'm not diminishing your value on those committees at all. I think that's part of the tension between role clarity. So what can staff do as capacity and what can we do as committee members given our monthly meetings and being an advisory body. So that's something we still have to tease apart.
So my assumption is Maria comes back and kind of reports back to the equity committee to talk about discussions and contributions, and also to bring that message to us. When I say us, I mean the workforce committee, so that there's this, we rely very heavily on staff members to provide that role of interconnection between the committees, I think. I was looking at the charter, the health equity charters in your package here, and under number 3, which is the collaborative work with other Oregon Health Policy Board committees and make recommendations, there's a whole list of items here. And so if there's issues, because you were asking what the policy board should do, if there's issues in which the policy board need to make clear direction to other committees to make sure that this important piece is engaged, then I think we need to know that. Because the workforce committee is called out specifically in here, but there's other committees that are called out here. I just think it's incredibly valuable, having that equity lens, and Maria's been incredibly valuable, and she's never afraid to speak up. And we really like having her at the meetings. So I want to make sure that the other policy board committees have that same opportunity. So if there's something there that we can assist with, I think we want to assist. I also feel like you have to be at the table. One of the last things on here talks about serve as a leader and catalyst for meaningful change in the health system, and I think you have to be at the table in order to take on that leadership role. And so I appreciate the thoughtfulness of the conversation that's being had, but I don't want that to necessarily get in the way of being able to be engaged and understanding also and contributing, I should say, to these other tables. So I think that's, when we talk about pace, I think that's one of my concerns, not necessarily action, but just being there, being present. And so I worry about that, I think is my concern if you guys aren't, if the equity lens is not able to participate.
Yeah, thanks for that feedback. I would say, on reflection, to me, it's not so much that there are necessarily active barriers around that specific work. I think, other than capacity, right? I think we have been working, like I said, on trying to stand up in our own committee, right? Making sure that we're active and engaged and we know what our expectations are and that we're moving forward on some of these big picture items that have very tight timelines like CCO 2.0 and stuff. And I think that's why we're planning on moving forward in the rest of the remainder of the year, meeting with the co-chairs of all these various committees to really kind of say, okay, now we have some breathing room. What are you working towards? What are your goals? How do we best support you? I think part of it is being there, right? And finding equity lens, but ideally it's beyond that, right? It's really helping the committee and the members to develop their own capacity to do that equity lens, so it doesn't rely on Maria or one of us being there at that moment to catch. No one wants to be the equity police, honestly, right? And so how do we?
She is not a
yeah.
police.
So
she's a contributor.
So how do we really work together to just boost the capacity of everyone, right, to kind of do this work? And I think, also thinking about how those tables look and, how do we, bring folks to our table as well. So, I think we are, it's not that people have said, no, don't come to those meetings or I think at all. I think it's more about not necessarily having the capacity and then now we do, and that's what we're hoping to move forward and to really be strategic around that and figure out how do we really just build capacity across the board so that there's lots of hands doing this work.
John?
Well, first, thank you for what you all do. One area that you might consider are the CCO community advisory committees. And I've been trying to encourage various folks I run into to participate in various volunteer ways. It surprises me sometimes their reactions to that. And I think it would be interesting for you all to get a sense of those and how are they doing and what suggestions can you make to them and what dots can you help the CCOs connect. They have expressed a lot of concern that they're challenged by getting a diverse group of people to participate. And I see some CACs that seem really great and are working well. And then I think about the open card. The open card has a CAC, how's open card performing in terms of equity issues and things of that sort, so at that level.
Thanks, that's a good idea, and we'll take a note so we can kind of bring this back to the full committee and work with staff to kind of prioritize these.
I appreciate your foundational work in terms of seeking community engagement, supporting the different committees, getting them and running, and your bias for action. And there's so much work that needs to be done. I would like to suggest a couple areas for discussion to prioritize the work. Looking at your definition, I think it makes perfectly conceptual sense. I read it, yeah, that's equity. As a public health dean, I might add well-being because not everybody realizes that full health is the absence of disease, but that's a small wordsmithing point. I think my major concern is as we go into CCO 2.0, we need something that's measurable, that can hopefully be incentivized. And that's going to be a big challenge to turn that into something, a metric. There's also a big challenge that we've learned through other deliberations on this committee is the data that we have to work with is really bad, incomplete. And the committee and the discussions here have educated me about the challenges of getting good data in a culturally appropriate, responsive way. That's not a small feat. But if we don't get the data and we don't believe the data is not reliable and valid, and we don't get a metric that's measurable, then we are really handicaps our ability to detect the inequities and then make necessary policy changes to raise the bar for everyone.
So thank you, and I think those two areas that you mentioned are reflected as primary initiatives in the work plan in terms of the real data improvement as well as the health equity metrics. So absolutely, yes, we're on the same page.
So much to do. I'm just saying, those are your North Stars there as I see them.
Absolutely, and that's how we've got that reflected. Thank you.
Right.
Again, in the definition space, I'm curious around the committee's consideration of geography. Last month, we spent some time in Lakeview, and I was struck so struck
Yeah.
about access issues, and this is coming from the big metropolitan area of Medford, so that is actually saying something really significant. So how did you deliberate the question of geography and rural isolation?
And thank you for bringing that up, because that was going to be my next comment, is geography.
Well, I'll start and feel free to add in. I think, with all of these, we struggled really again with balance, right, around having a definition that was succinct enough that folks could work with it and remember, or at least call it to mind a little quicker. So try to limit, like, where do we stop, adding groups and how do we list them. I think that's a great suggestion. I think that's part of why we're bringing this out before it's finalized, is really get that kind of input and see what folks are saying, and that may rise to the top. It might be something that we need to consider adding. But I think for us, it was really around this: how do we? At what point do we say, okay, we've tried to capture enough, and it's like or other circumstances?
No, I think that was the biggest tension, was do we create the A to Z list of inequities that exist, and also hold a definition that could change over time. New inequities can come to the forefront. So, I would be curious to hear from you all in terms of looking at a definition that includes, that entire list versus something that's more simplified that everyone can potentially see themselves in. And you don't have to provide feedback now, but that is something that was the main point of contention when we were working on this.
And I think that what I wanted to note is the fact that the committee and all of our advisory committees are indeed statewide, so we are getting those perspectives, those voices at the table. And no matter the location of the populations or the individuals that are experiencing health inequities, we have to always consider the intersectionality of that geography with these categories or demographics that are identified here. So we're talking about not only all of these areas, but how that manifests statewide, and the fact that if you look at a rural area, very likely you will still see higher inequities and greater gaps when you look at these specific populations and intersecting those with these specific demographics.
Any other comments or questions? All right, thank you very much.
Thank you, we appreciate your time.
All right, we will be moving on to the Public Health Advisory Board. Yes, we'd like to join us. And David, did you want to do an introduction?
Pleased to do a short introduction to welcome Rebecca Teal, the chair of the Public Health Advisory Board, and Lillian Shirley, the director of the Public Health Division of the Oregon Health Authority. And just make a comment that how much I enjoy being on the Public Health Advisory Board. While public health in Oregon is terribly unresourced, we are upstream and making incredible differences with the resources we have to improve social determinants of health, such that we don't have to spend so much money in the healthcare system to improve health status. And Rebecca's done a great job leading the group, and as well as OHA's support.
Hi everyone, welcome. Thank you for having us. This is hard to see. So, as Dr. Bangsworth said, I'm Rebecca Teal. I'm in my second year as chair of the Public Health Advisory Board. My day job is I'm director of public policy for the Hospital Association, and so I have a really great perspective. I fill the seat of healthcare representative that's not a CCO member. And I'm very used to these mics because we have our meetings in this building, so they are complicated. So for our agenda today, and I'll be doing most of the talking, and then I think Lillian, you'll fill in where I mess up or ask questions. We're going to discuss the role of public health in achieving statewide priorities, talk about some of the great work that we've done in the last year, and then what we have sort of on deck for the rest of the year and for 2020. We've been achieving a lot lately. So this is a great graphic that we like to show in the beginning of presentations to really show that the public health system is really a network of federal, local, and state health authorities It's really about government-to-government relationships between these entities and then also with our tribal partners in the state. The public health system is charged with preventing disease, protecting people from harm, and promoting actions that help people stay healthy. And one of the things I like to point out that's a little bit different from the charge that you all have when you're thinking about the Medicaid population is that the public health system serves all 4.2 million people that call Oregon home. So we touch everybody's lives in the state. One important thing to note about Oregon in particular is we have a decentralized public health system. So those local public health authorities, which is served through the counties in most parts of the state, is really where that authority lies. Some states have a much more regional or centralized public health system. So when we think about the goals of sort of this body and all of the subcommittees of the Health Policy Board around the triple aim, the public health system is really essential for making progress in these areas. The public health system really does focus on all three of these, but in particular thinking about preventing people from either even entering into the health system. So all of the work that you heard this morning around the cost of care, we can really do a lot to help people not even have to enter that system and then face those price and cost challenges. So by focusing on prevention, we really lower demand for healthcare interventions. The next area, I want to show you a graph that you've all probably seen over the last, decade or 5 years around the role of social determinants of health. We know that 90% of what makes us healthy or does that prevention work that I just talked about is really not about the healthcare system, but about the social and environmental factors, individual behaviors. And one thing I really want to sort of pause here and share is, particularly from my world, thinking about from a healthcare perspective, there's different views on how to address the social determinants of health. And so, as an example, there's been a great announcement yesterday. Kaiser is, for example, implementing a really great new system within their EHR referral that will help screen patients and then refer them to community resources. If you think about if someone's experiencing food insecurity, it'll help them connect with community resources, and that's one way the healthcare system is addressing social determinants of health. But the public health system would really be asking the questions: why are people experiencing food insecurity to begin with? What is the quality of food that they have available to themselves in their communities, in their workplaces, in their schools, and sort of even more upstream than referring them to a program in the community. So just stop there. Do you have anything you want to add?
It's just sort of the Reader's Digest version of this as we're going forward with such an integrated system and everyone really understanding the need to go upstream. The way I think the distinction we're trying to make with our partners and our partners across OHA as well as our partners in the community is a lot of that work is really addressing the impact of social determinants of health on an individual and trying to mitigate that, get them to food, get them to housing. And it gives us an opportunity, I think, in Oregon to step back from the public health frame and really think about what are the systemic and structural issues that get them into that first, and not the consequences of a social determinant of health, but more of making sure that there aren't those differences in how people experience their life cycles.
Great. So in terms of where we live, the Public Health Advisory Board, in this graphic that I believe you all have seen several times, let's see, we're right below the Health Policy Board here. We're a governor-appointed committee that has a 17 board member that includes state and local public health officials, a tribal representative, CCO and other healthcare organizations, and then we have a population metrics expert and someone who represents academia, and then Dr. Banksford serves as our liaison to this committee. So we're the accountable body for the governmental public health system. So when you think about that network I showed, those are all government relationships and relationships with tribal organizations. There's a lot of public health work that happens at the community level through nonprofit organizations or other entities, but really our role is to advise on the governmental health system portion of public health. And we make recommendations to you all in that vein. and we have 2 subcommittees that are very active. One is around accountability metrics, and one is around incentives and funding. So there's a lot of work that happens via our subcommittees, as Dr. Banksburg knows. We get great reports from them. One thing I wanted to highlight, so I presented an update last year to this body, and we spent quite a bit of time talking about that first bullet around our health equity policy and procedures. So I believe 2 or 3 years ago now, the Public Health Advisory Board established a policy and procedure where any action that comes to our board, we really run through our health equity policy, and we ask that anyone that comes to present to us, there's a set of key questions that we have them think about related to health equity. We just reviewed that policy this summer and voted to keep that policy, and then we also had a discussion about aligning whatever the definition that the Health Equity Committee establishes, that we would make sure that we stay aligned with that work. But I did want to add, there's 2, I don't know what color they are, yellow items that are new from this body of work this year, is that there's been some work with regional health equity assessments. So in the few slides, we'll talk about some actual investments that have been made in communities and the focus that they've been making on doing some assessment work at the local level. And then at the division level, so with Lillian's leadership, the Public Health Division has established a health equity work group that's been doing quite a bit of work internally. I don't know if you want to add to that? No? Unless there's questions about that? Okay. So, our key accomplishments for this year, before we get into that, just a refresher about the framework that we like to use. So, the Public Health Advisory Board and the system is on the pathway that we call modernizing the public health system. So if you've been on this committee for a while, you've been hearing this for the last couple of years. If you're new, this is the framework that we like to use. It was adopted by the legislature in 2015, and it really builds upon a set of foundational capabilities and programs. So the bottom line goal of public health modernization is to make sure that all of the things that are in the box exist for everyone in the state, no matter what community you live in. And that public health, the role of public health is to assure that those things are present in communities. And so those things include communicable disease control, prevention and health promotion, environmental health, access to clinical services, and then the icons that sort of live below that are the capabilities that are needed to address those areas. One of the reasons why it's so important to move towards a modern public health system is that the landscape for public health has changed dramatically in recent years. The new public health challenges are increasingly complex when you think about things like climate change and rising rates of chronic disease and our aging population. And so modern public health really needs to have a new set of skills and tools to address those challenges. And we've been at this for quite some time. Here's a timeline that shows how long we've been talking about public health modernization, starting probably even before 2013, but 2013 was really when the initial legislation was passed. You'll see there's quite a few bills related to this work on this timeline. So we have really strong legislative direction that this is the way that we need to go in Oregon. And that's been helpful for us as we've been thinking to make decisions. We know that we have the support of the legislature. And the Public Health Advisory Board has key decision points along the way. But you'll see here in March 2019, one of our milestones has been related to accountability metrics, and we'll talk a little bit about that at the end of the presentation. So just to highlight, when you're thinking about what does a modern public health system mean, this is a very simple sort of compare to traditional versus modern public health systems. So you think about a traditional public health system, there's a lot of categorical funding. You can think of, the Centers for Disease Control and Prevention gives the state a grant for asthma, gives the state a grant for HIV, gives the state a grant for heart disease. And all of those categorical funding have different and sometimes not aligned things that they need to do to accomplish to keep being competitive for those dollars. And so a modern public health system, there's alignment, and programs and staff can adapt and be nimble and flexible to emerging needs within the system. A modern public health system emphasizes partnerships rather than siloed and competitive or categorical programs. And the data systems are complete, dynamic, integrated, and generate useful information for achieving action. Other questions about the difference between traditional and modern?
I really like that slide. I haven't seen it before.
Yeah?
That's a good slide. Yeah, it is.
Is it fair to say that part of what we're trying to do is modernize the state funding of public health in the face of fairly slow progress modernizing federal funding?
Yeah, I would say that's an accurate statement, and I would say the history of modernization, which you could go back and look at the timeline. The original brainchild idea from Representative Greenleaf was create 8 regions, and that will solve some of these problems to get toward a modern public health system. A task force was formed around that idea, and they dove a little deeper into that proposal and identified that really it is an infrastructure problem. It's not, if you regionalize, you're not going to achieve better outcomes, and infrastructure is usually a state responsibility. And so I would say your statement's accurate. Yeah.
I have found it useful as we've been talking with our Ways and Means subcommittee that just the ordinary flow of things, while they're in session, we bring them grant requests for their approval. And we did a presentation last week on modernization after 4 or 5 grant requests that they had considered. There were these very sort of micro-categorical grants, and that juxtaposition, I think, actually really helped them kind of see what we were getting at in terms of where we're trying to go with modernization.
Yeah, I don't know how, you probably know off the top of your head, how many grants flow into the state. I mean,
63.
Yeah, it's quite siloed, and so that infrastructure piece is really important, because when you don't have the nimbleness to respond, and you're chasing and you're reporting on your little tiny grant. I mean, I used to work under a CDC grant, and every quarter you're reporting on how many pamphlets did you hand out, and that is not what we're trying to achieve here with this system. So let's see. So funding, that's a great segue. So we, as the Public Health Advisory Board, advise on public health funding. In statute, which is referenced there, there's a public health modernization funding formula that we're in charge of advising on, which there are 2 components to that. One is a base funding component and one is an incentive component. And this year we've done a lot of work on developing principles related to funding. You'll see at the bottom there that the one and only investment that's been made from the state levels, from the state legislature, has been a $5 million initial investment that came in the last biennium. And so we've done quite a bit of work to build principles around a spectrum of potential options. Whether 5 million is the right number, I don't know, but we really want to be able to build out those principles before there's any sort of investment made into the system, and thinking about what sort of lands in a base and what lands in a more competitive incentive environment. So that initial investment you're seeing right here on the screen, because it was a $5 million investment and we wanted to be able to demonstrate outcomes, one of those foundational programs was selected, and that is communicable disease control, in order to really sort of dive down into how these funds can be used in a modern public health system. And you'll see that there are regional projects that were developed around communicable disease control with strategies that are aimed to eliminate or reduce health disparities. 33 of the 36 counties have been touched by these grants, and you'll see that even though the funding was sort of bound by one program, communicable disease, they're all addressing something slightly different. So you'll see this, I don't even know what county is that, Clackamas. Metro County is working on hepatitis A and C and latent tuberculosis, where if you look at the eastern region, they're focusing on gonorrhea prevention and control, and that's because they're addressing the needs of their local regions while sort of still living within the same bucket of a modern public health system.
I think it's important also to remember that their priorities are associated with
the community health assessments and the community health improvement plans that not only the local public healths in the regions around the state have identified, but in conjunction with their hospitals and their CCOs. So that's how those priorities have come, to the fore. And one of the requirements that we had is that you had to pick one of the top 3 in your own local improvement plan.
So we are already seeing results with these projects. The 3 main things that we are seeing that when you actually get infrastructure dollars that are a little flexible is you can create some really innovative partnerships, both intergovernmental, so as we saw on the last slide, regional partnerships, so working across counties, having shared staff. That's a big deal when you can actually share staff between county lines and have MOUs in place and think about how those teams are built regionally. That's not something that can occur with categorical funding. And then partnerships outside of the governmental health system, so partnerships with health systems, tribes, regional health equity coalitions. And so the initial evaluation results is that by having infrastructure dollars, you can actually do some really innovative work with partners, and then that leverages additional dollars. So for example, the Lane County project did a really good, I forget what they were working on. They worked with Peace Health System and were able to, immunizations, and they were able to leverage dollars from the Peace Health Community Benefit to actually purchase vaccines, something that you wouldn't necessarily be able to do with these state dollars, but by being able to open up that ability for them to partner, they were able to leverage additional resources for the community. So it's a really great example. So now I'm going to shift focus to public health accountability metrics. So thinking about having a little more flexibility with dollars that you're receiving for infrastructure, working regionally. The way that this is all tied back to accountability is that there's a set of statewide accountability metrics that are developed and advised upon by the Public Health Advisory Board to track progress on big goals. So we're doing this great regional work together. There's a little more flexibility with the dollars, but at the end of the year, we're sort of checking back on, are we making progress on statewide goals together as a system? And that's what this report does. And in that report, there are 2 types of metrics. One is an outcome measure. So these are population health priorities for the entire system, for the whole state. And then there are local public health process measures. So this is really trying to capture that daily work of the local public health authority to track progress in that way.
So I I think it's important for the policy board to know that more than half of the health outcome measures that have been identified by the Public Health Advisory Board align with the measures, current CCO incentive measures.
Great. Let's see. It's really hard to see. So the key findings from the Public Health Accountability Metrics report. So when I presented last year, I presented the baseline report. We went over every single metric that went into the report, and then we now have our sort of first year of data to compare how we were with the baseline. The 3 main results are that the investment has been strengthening capacity for improving childhood immunization rates. Rates of gonorrhea continue to increase at an alarming rate. We'll talk a little bit about that. So there's a lot more work that needs to be done in that area. And that public health brings health considerations to the forefront in land use and transportation planning. And this is a sort of new emerging piece of public health that we'll talk about in a couple slides. So to highlight the childhood immunization metric, let's see which one we have up here. This is the health outcome measure. So percentage of 2-year-olds who receive recommended vaccines. You'll see that there's a benchmark there that was established of 80%. And this page shows that there are variations in 2-year immunization rates across racial and ethnic groups. So as Dr. Bangsberg said when we were listening to the last presentation, public health for these metrics, we we work to use what data we have available, which sometimes there are gaps, to report by race and ethnicity. And there's a really great work that we did. I actually pulled it up here around how we frame that. So where possible, data are reported by race and ethnicity. Differences in rates across racial and ethnic groups occur because of generational and generations-long social and economic and environmental injustices that result in poor health. And these injustices have a great influence on health outcomes. So we have that piece in the beginning of our report as a really important reminder as to why we report this data by race and ethnicity. So I think there was some great work that was done to have that appear in our report. And then we show by region. So you'll see that by county, rates are different, and I think, I don't know the color. Do you have color? No one is close to the 80%. There are some communities that are closer, so more work to do around childhood immunizations. And then we show the process measure. So the first two slides on the report, if you were to pull up the report, is the outcome measure and then the process measure. So the local public health process measure for two-year-old immunization rates is the percent of vaccines for children's clinics participating in APICS, which is a national quality improvement program. And you can see by county where they moved. There's little bubbles where the benchmark is, and I believe the lighter color is 2017 and the darker color is 2018. So this shows process at the local public health level. I'll pause here and see if there are questions about how this report is laid out before I talk about gonorrhea.
So, yeah, I just, we're at the beginning of our, with public health, changing our culture to really be accountable and to work toward these. So this measure doesn't necessarily say we've changed the rates of childhood immunization, our ultimate goal, which is outcome, but it's working as a process measure to make sure that we are setting the stage so that individual private practices for pediatrics and primary care and hospitals and community clinics can understand some of the tools that are available to make it easier for them to achieve their goals, and which is also important because it's aligned with the CCO metric for having people get their accountable metrics into the CCO. So we're trying to really tell that story from the beginning to the end, and what does each part of OHA contribute to achieving the overall goals for health.
So I have a question. So what is the connection between state public health and the local public health agency? Like, what is the governance there? How does the state agency impact the local? Is it carrot? Is it stick? Is it shaming, as Dr. McConnell talked about?
So we're public health. We're not healthcare, so we're not into shaming. But
You kind of are.
except around smoking, but other than that. But the relationship is we have, I think, as Rebecca identified, we have local control. So it's set out in statute. It is a system. So one of the examples, I know Director Allen's going to tell me, Lily, and you're going into the weeds or you're losing them. It's hard for me to stay up because I'm so into this, but I'm going to try it. Okay. So when you have something that we have no governance authority over, but in statute it says what is the role of the state, what is the role of the locals to achieve that combined outcome for a population. And that's been going on for as long as there's basically been a state of Oregon. But if you look at what we're trying to do with modernization, we're really trying to, Dr. McElvery, really define what is the appropriate role for the state, which is not to deliver individual services, and how do we support what's happening on the local area. So we've embarked on a system of memorandums of understanding across our state agencies so that we can support the work at the local agency. And for where you live, I mean, a big issue has been, for instance, smoke in the summer from the wildfires. So the state agencies coming together to look at it across forest, across fish and game, across public health, what is the impact? And we have those roles, but we're saying that one of the ways we want to encourage in modernization, the capabilities like leadership, we want to make sure that at the local level, we're able to bring in local public health around what is the impact of this, whatever the topic is. In this case, we're talking about wildfire smoke, on human health in your region, and how can we support the locals with data, information, and trending to understand, what needs to be looked at, anticipated. So that leadership role, which is different than just funding a program or funding specific activities. And we meet with them regularly. We have committee work that we bring to the Conference of Local Health Officials in different areas. So it's really trying to define what lane you're in and who should be making what decisions, and making sure there's not duplication. And also encouraging on the local level, beyond the governmental system, what is it that are the community organizations and the community voices, and how can we have that impact what we're deciding are our goals. And at the end of this presentation, we'll talk a little bit about our new state health improvement plan and the process we went through to really get us at the state to turn around how we think about what's driving our work.
Okay.
I know that, I'm sorry, took too much.
So it's
I know, I blacked
pass-through.
out.
It's all right. This is a pass-through relationship where we hold some accountability, the state holds accountability, and then really provides infrastructure for data. I mean, like if you think about the behavioral risk factor surveillance system is something the state owns, and but yeah, it's a partnership.
Okay.
Did you? Yeah. I just think this data is really interesting, but I have so many more questions about it, and I'm curious to. You partially did answer this, but it was like, okay, what happens next, and how does that interact with local authorities? But is there deeper analysis to identify trends, or why? Because there's really dramatically different things happening in these different counties, and some of these I'm like, they only have one clinic. How do you go from 0 to 100, or how do you?
That's one clinic.
It could be one clinic.
Yeah, that's one clinic. I can tell you that.
Yeah, is there a deeper analysis that's done here to take either let's set that aside as an outlier, or here we see some trends, how do we pass down these success stories into?
Yeah, I would say there's a full report that you could look at that I don't know if it's in your packet or linked somewhere, but this is just one data point from the baseline. So I think it'll be a while before any sort of trend, analysis can occur, but this is the snapshot. But yeah, there's a lot of what's the story that's being told here. I think that's a great question. You'd have to really sort of, sit down with one of these communities and say, what did you do that was a facilitating factor of success to get you from A to B? And it's probably different for every community. Yeah. So, other questions about the data? All right, so now that you have the structure of it, we're doing 2 more. I think we're going to do gonorrhea next. So another important metric for the communicable disease area is gonorrhea. So it's incidence per 100,000. Unfortunately, the news here is not positive. Between 2016 and 2027, rates have continued to rise. So you'll see the lighter color is 16, the darker color is 17. That is across most populations. There's particularly in this area stark differences that we see in cases by race and ethnicity, particularly with the African American communities are experiencing the most harm. And I think this is really important for public health modernization to continue to think about how we address this area. You'll see by county or region here, the benchmark is 72, and there are some communities that are quite higher than 100 for this area. That's the health outcome measure. When you think about the public health process measure, there are two public health process measures for this area. This one is the percent of cases that had at least one contact that had received treatment. And so some local public health partnerships are using their modernization funds to improve tracking and case management. We likely won't see, results from those investments in this year, but this first measure really looks at tracking partners and individuals who have been identified as having gonorrhea, and then making sure that those partners are treated appropriately. It's so hard to read up there.
So the interjection to stop is to get the next generation, to find out, who was the contact, and to really work with the community to make sure that we can identify them. Again, Dr. McCalvary, on the local level, just as people know their communities, and it also means that it has to be culturally appropriate. It might not be a governmental agency, it might be a community-based organization or a mutual assistance organization to work on that. But rather than just identifying the case, getting it to the lab, and treating the individual, the focus here is to the interdiction of the communication of the disease across communities.
And then the second process measure related to this is around data reporting. So it aligns very well with what Lillian just described. But the priority field part is sort of the wonky term. But wanting to make sure that the data reporting is complete, and it includes all of the priority information that's needed to understand which communities are most at risk in order to target interventions for these communities. So again, at the process level, it's really about accurate data reporting and accurate tracking. I'll see if there are any questions about gonorrhea. Yeah?
So is there, this is probably very messy, but is there any integration with the private delivery system? I mean, do the physician practices in an area have any sense of how much gonorrhea is occurring in their populations? I mean, I know they report a subset probably, but my guess is there's probably a lot they don't know about. I mean, is there any integration in terms of data?
Well, yes. I mean, I think that one of the things that the Public Health Modernization has helped us to do is people were just seeing what came in the door for their practice. But by having these outcome measures and accountability measures, it gives a broader picture to a community, and those things are turned over. We also have been able to use the CD reports, which goes to every single physician, nurse practitioner licensed in the state. Around topics like this, but giving one of the things that we think, this is just kind of conjecture, but because there was not attention paid to this particular communicable disease and people thought it went away, it's a hard topic to talk about, when you see some of the differences in the communities, there's a certain number of people, like the measles outbreak in the Hadassah community, there's a certain number of people in Hadassah, and they are passing this around. It's not anybody's fault. That's who they socialize with. That's who they shop with. That's who they go to dinner with. And some of those same dynamics were not transparent, I think, before. So having this data and being able to present it exactly to your point, it gets physicians in other parts of the state to understand that the other interesting thing that has been demonstrated by the work of the modernization money and the reporting is everybody thought it was someplace else. Sexually transmitted diseases either happen in urban areas or they just happen along the I-5 corridor. And we had a Ways and Means presentation where we were able to demonstrate that this is something that's across the state. There's no them, it's all us, and really have raised that visibility helps people to address it and to think about it when they come into private practices.
Is there any correlation between the populations that are getting this and their behaviors around social media?
I have no idea. I don't think we've not looked at it, and I'll see if someone else has looked at it. I'll get back to you if I understand it.
Great. So the last measure I'll share with you So I'm doing all of them. So again, you can look at the report online. I believe there are 30-something measures. There's a lot of measures. But this is one of our, I would call, sort of emerging areas. This is related to active transportation. So the Public Health Advisory Board recognized that active transportation and transportation is an emerging field within public health, thinking about the connections between the built environment and physical activity. This sort of has emerged. So we did adopt a measure to bring attention to this, though you'll see that we don't have any comparisons. This is just comparisons against other groups. This is just a statewide benchmark. At the time, we're using the U.S. Census American Community Survey, and so the benchmark is 9% of commuters who walk, bike, or use public transportation to get to work. And then you'll see that by region or by county here, where the 9% is, and it does vary across the state. There's been no, real changes from last year, but this is a new area. We have a lot of conversation in our Public Health Advisory Board about how rural communities are impacted by this measure, and lots of discussion around, someone says that they've actively gone to work, that they are working on their own property, something that they just walked from point A to point B. So recognizing that Oregon is a geographically quite diverse state, but still really wanting to have this measure in here. And so the local public health process measure for this piece is pretty much is about partnership. So it's the local public health authority participating in leadership or planning initiatives related to active transportation or parks and recreation and land use. So it's a little broader of a process measure, really just wanting to get public health in seats at the table in leadership roles and thinking about even as land use planning. You might not see that in the outcome measure, but really wanting to recognize public health's role in some of these community planning decisions. And so you'll see which communities had sort of did or did not participate in planning.
And just one quick, from the beginning where there was like 2 counties across, over 50% of the counties after we instituted this measure are working in their own communities around this issue.
Great. Any questions? That's the last measure we're going to cover. Yeah?
How can you update the benchmark?
Every year we'll be updating this report. Yes. Yeah, annually.
You update the report, but the benchmark.
Oh, the benchmark? I don't know. I don't know.
That's a good question for the fact.
Yeah, we'll have to consider that. I mean, I don't know if there's evidence base around when, if you're every 5 years, every 10 years, when is the benchmark move? But that's a really good question. We'll take that. I think the subcommittee can noodle on that one. I'm not on that subcommittee, so they do great work. Other questions about, yeah?
I had a question on the gonorrhea rate, this map. I heard John's question on the delivery, and I guess my concern on here is Jefferson County and Umatilla County, and both of those have Indian reservations located on them, and they're the only 2 treaty tribes in the state of Oregon. The other tribes are not treaty tribes. And most of us there use clinics, the Yellow Hawk Clinic and the Warm Springs Clinic. And just Jefferson in particular is really high. And I'm just wondering, the delivery, education, prevention, do you ever, is there ever any, what's the reasoning behind this? Is it, are these just for numbers' sake, or what? I mean, what is it we can do, or, even like for my tribe in Umatilla, because it's at 83, and even the Klamath too is 89, and that's near a restored reservation. So I was just.
Yeah, I think it is raising the issue and working with the local providers. We do have a once a month meeting, mostly telephone meeting with all the medical directors of all of the 9 tribes, and, you know, give them back feedback on what we're seeing. Also asking them for their input about work that can be done. But we work with the clinical systems on the reservations as well. So it's, again, you know, I think it's one of those things that we weren't paying attention to, and what can we do to make sure that communities are aware of this issue and what can be done to interject in any of the transmission. People think of one of the community meetings we were at, I thought it was informative. Somebody said when they thought of gonorrhea, they thought, you know, that just, you know, you find out you have gonorrhea and you get your medicine and that's the end of it. But you don't think about the sequela, the medical sequela, which can, you know, have consequences for fertility and public inflammatory disease and things like down the road, you know. So it made people understand that this is more than just, you know, kill the germ and move on. So that's part of the work that is ongoing. Hopefully we'll have better results when we come back in at least 2 years from now with the outreach work that's going on. And to your point too, information, do people know about this? Do they know what it means in their community, and what is the advice they give us for how we can communicate around that?
Okay, thank you, because I mean, this is, see, I had no idea, you know, about these rates, but now I do, and I'm sure that maybe the medical director at our clinic knows about it too, but as far as I know, the community, I mean, there, and I don't know about Pendleton's, the largest, what is it, city there, and it's like 14,000, so we're pretty small there to, you know, for these kinds of rates, and you'd think that we'd be able to, because of the small number of people, communicate and, you know, be able to, you know, address this. And so that's why with this kind of information, you know, we need to hear it and, you know, there too, and I'm sure that we will. I don't know, you know, with you folks, like with the public health, we have a Umatilla County Public Health Department, and it's a very small building there, and I don't know how many people use it. I'm sure some people do, but it's not, most people just go to the ER, it seems like it. So, okay, well, thank you.
But thank you for that feedback. I'll make sure that we follow up specifically.
But, so if the tribe wanted to participate in finding contacts and getting those contacts treated, could the tribe do that?
They do. Yeah, no, they do. Yeah. This is not exclusive, and also I think, I'm not sure if this is in the talking points, but one of the things going forward for public health modernization, which was not in the first 2 years, Dr. Santa, we worked mainly with just local governmental public health, but the work of the whole Oregon Health Authority's Public Health Division, you know, works beyond that, you know, around communicable disease. But this year, we are including any of the tribes who want to identify work that they want to do specifically for modernization dollars. If that happens, you know, after the legislation, we are including the tribes to be part of that system.
Rebecca Lilly, great job. Absolutely superb. Summary of a lot of work. I'd like to just take the opportunity to make 3 points of how the Public Health Advisory Board has informed some of my thinking on the Oregon Health Policy Board. Some of these points are very familiar mantras I've emphasized before, and some of them are, I think, are evolving. The first is, you know, we've seen in public health modernization how the CCOs have really partnered with local health authorities to move upstream in social determinants of health and to look at the population level, not just the clinic or people covered in the clinic. And so I think we've seen great examples of that in Informed CCO 2.0. I think another example that was shared today is cross-sector collaboration with land use planning in terms of active collaboration. I'd like to see more of that in terms of criminal justice and foster care, housing and education. And the last part is just looking at the data and the accountability by county, and to see the heterogeneity between counties, and then to use that heterogeneity to dig deeper as to what's going right and what's going wrong. I really like to see that type of data quality and accountability and transparent reporting as we move into CCO 2.0. Because I think it's really informative. I think we've heard from CCO directors that they're open to that. They want to learn from each other. And I think that the county, the public health system really has created a best example, best case scenario for what we can strive for with CCO 2.0.
Great, thank you. And we've really appreciated having our liaison on our meeting. So I'm not quite done yet. I have a little bit more to go. Real quick, I wanted to do one slide on, I don't think we've shared this with the Health Policy Board, but another area of our work is advising on the Preventive Health and Health Services Block Grant. So this is actually one of the only grants that the state receives that is a non-competitive federal grant that has some flexibility to it. And so you'll see the 4 bullet points of how those dollars have been used. We get $1.2 million, so it's just a little bit of money. But we really use that for implementing the Public Health Modernization Plan, doing some local and tribal training and technical assistance, and you'll see the 3rd bullet there is related to the State Health Improvement Plan, which I'm going to talk about in a little bit, and I was happy to see that's sort of the rainbow thing on your work plan now. I'm excited about that. And then for public health accreditation. But moving into sort of on the horizon for the next year and thinking about what Public Health Advisory Board will be up to. Here you can see our phased-in approach. So in sort of phase 1, we're still working in communicable disease control. This was the initial investment that we received from the legislature. We've seen a lot of improvements in this area and hoping to sort of really continue to do that work. Also making sure we have resources to think about and make progress in the health equity and cultural responsiveness, and then the assessment and epidemiology. And then the plan is as infrastructure gets built and regional partnerships take shape, that we would work sort of from left to right in this document. So this is our sort of broad work plan. But going to our other big focal work that's not quite related to modernization is around the State Health Improvement Plan. So again, that rainbow piece on your area. The health authority is responsible for setting statewide health priorities and conducting a state health assessment and state improvement plan every 5 years. So we've been providing oversight and direction for what we're calling the SHIP for monitoring and progress. And a number of FAB members participated in both the steering committee to lead that work. I believe Dr. Bangsberg, you and I were on some of that work. And in 2018, we published the state health assessment. And so it's really a 3-part process. There's a state assessment, community feedback, and then the state health improvement plan. That middle bucket, the community improvement process, there were a couple different forums for people to provide community input. There was an online survey that was available in both English and Spanish. There were other forums such as email, social media, formal letters. My understanding is that if you didn't quite use the correct survey link and you just emailed somebody, that data was included. There wasn't a no wrong door approach to provide feedback to the health authority on this. And then there are some mini grants to community-based organizations that you'll see listed here to hold forums and get community input on the state health improvement plan. So you might be familiar with some of these organizations in your communities. So using a mini grant model is something new that the health authority used for this process, and I think it went well. The reason we know it went well is because we got over 2,500 people providing feedback into the state health improvement planning process. There were some consistent themes that emerged around social and structural determinants, and that a lot of the issues were interrelated and interconnected. We had racial representation in the 2,500 folks that provided feedback. There were more women than men. We did have underrepresentation of people with less education. We had a lot of the people that responded were women who had higher levels of education, so we need to think about how we get beyond that as our majority of responses. We did have areas outside of the I-5 corridor represented. One gap that we had was the youth voice was not strongly in this survey feedback. So again, we need to think about how we get that voice in our feedback. But do you have anything to add on the feedback process? So, see if you can see that. So of the responses and why there's an N of 1,400. So this was from the online survey piece. Not the forum piece is a little bit of a different process, but the top 6 issues were housing, access to mental health services, ACEs, trauma and toxic stress, living wage, substance use, and access to care. And so sort of once it goes down there, you'll see, food security and others. The steering committee did quite a bit of work around looking at this feedback and pulling common themes and trying to understand root causes in some of these. And then after careful consideration and working with the steering committee, these would be 6 areas that the SHIP steering committee selected based on the community input process for the 20 to 24 state health improvement plan. So those are institutional bias, adversity, trauma and toxic stress, economic drivers of health, access to equitable preventive health care, and behavioral health. So we did a little bit of lumping together of some of the areas to get us to 6 now. 5.
So can I just, we also cross-referenced it with all of the outreach and community meetings that were done for CCO 2.0. And there was a lot of overlap in that, as well as some of the listening sessions that were not this year from CCO 2.0, but the behavioral health, going out to the community to talk about behavioral health. And there was a lot of consistency, and we also were pleased to find out that it also aligns with Governor Brown's priorities. So I think that, again, this theme of integrating and alignment is being carried through from what the community is telling us, and we're really trying as an agency to respect that and to figure out the best way to turn that around in terms of what we do.
Yeah, that's great. And this has been really good sort of thought process for we have our public health metrics person on the committee. It's like, how do you measure these, right? And so this is going to be a really great process for the state to think about these priorities and how we move forward together. This isn't just the Public Health Advisory Board's plan. This is your plan. This is our plan. This is everybody's plan. And thinking about how we move together in these areas and really be open to how we can innovate around them as well. So the next steps for this body of work is there are subcommittees for each of the 5 areas. There will be work plans and further community input. The subcommittees, the staff is doing some really great input or outreach to get subject matter experts, cross-sector partners, and people with lived experience in all of the areas. And then the final product will be ready in early 2020. So with that, we have our key questions at the end here, or we can talk about the SHIP a little bit more, but that concludes our slides.
Thank you very much. That was very, very thorough. So we have about 10 minutes left for questions. And so I'm going to use some of that time. The thing that I'm interested in about the SHIP is how it ties with CHIPS. Because it feels like to me the SHIP should almost guide CHIPS, and I understand CHIPS are local plans, but at the same time, I like this model of collaboration and connection, and I always get concerned when you have 2 different priorities being set. So if you have a state priority that doesn't connect with the local priority, then is that local health agency having to work on their agenda and your agenda, for lack of a better word? So I'm interested in that. Also, I sometimes feel like CHIPS are not as evidence-based so that they're trying to achieve things that it's difficult to achieve. So there's good intentions, but it's not realistic. And then the last question that kind of ties into all this is how do your metrics tie in with the quality metrics work that's being done? Because it feels like to me that should be a very robust relationship, so that if needs are being identified out of public health, that somehow that should connect with metrics, so that then that can be attacked from a state. That's another avenue that can be attacked from a statewide perspective. So for example, the public transportation, I think, is a really interesting metric that you're looking at. And essentially, I think what your goal is to get public health engaged in those conversations. That would be really interesting to bring that somehow into the metrics committee, so that that then becomes reinforced there, I guess is the best way to put it. So.
I'll take a crack at one of the questions. So one of the other milestones for the FAB that we had done, I think it was closer to the end of last year, was put forward recommendations to this board for CCO 2.0. And one of those recommendations was around exactly what you said, around alignment with the SHIP and the CHIPS. And I believe that there will be some sort of requirement to at least align or look at the state health improvement plan, and whether I don't know how it came out, address one or look at one or think about one or two or more. But there is some, my understanding, sort of contractual tie to at least think about how the SHIP informs at least at the CCO level. And then from a hospital perspective, we're also in that and having to coordinate our federally required community health needs assessments. And so using sort of, there's all three of those, that where are the overlaps, and then how do investments get made and where the overlaps are. I think it's going to be really exciting to see what comes out of the next sort of 3 to 5 years with these 3 different requirements. Do you want to tackle metrics?
Sure.
Okay.
We do have Eli, who is on both committees, and actually they either met this week or they're meeting next week. Katrina Hedberg will be presenting to the
Tomorrow.
metrics. Is it tomorrow? Yeah, tomorrow to the metrics committee, and we have regular updates with that, and we also get feedback from that committee. Because they're the certified smart people in terms of measurement, so we try to take their input. I do want to say, about the CHIPS and the SHIPS and the, yes, it is in CCO 2.0, the RFA, but also I see these as kind of, all the little tributaries that ultimately give us the Missouri River and the Mississippi River, and
Or the Columbia.
Or the Columbia, right.
I'm gonna say.
So what we've seen is in some areas of the state, locally, the region has come together to do this. In Eastern Oregon, definitely in the Central Oregon area, where they actually work together on that. And then the 2 years, almost 3 years ago now, when we first did our first roadshows, asked about this, because all of these things used to be done. People got in their cubicles, and looked at the epidemiology data and said, okay, here's our priorities, but when we started taking it out to the community, one of the things that we did the last iteration was public health did a crosswalk between all of these in the state, all the CCOs, all the hospitals, and all the local public health. We had this amazing spreadsheet, that had everybody's priorities crosswalk. And there is a tremendous amount of stability and consistency with what there are. I would say that across the state, if you took the top 5 in everybody's plan, at least 3 of them are consistent across. But again, when we were talking about how the tribal areas know about this, making this visible to people so that they could see that, and St. Charles could see that their priority actually fit in with the CCO, and it was also a priority of the Tri-County health improvement plan that was done by the county governments and public health. So that also was a driver to bring people together to realize that they're all working on the same thing. And I think that organic nature of the work is what we have a commitment to promote and see that they all get into the Columbia River eventually.
Joby?
Yeah, I just wanted to say that we actually, I think, saw that on the ground, a wonderful example of it when we were in Lake County. And we heard so much about how the county has integrated with the hospital there, the hospital taking over some of the public health responsibilities, and then the way the CCO for Eastern Oregon reports at a county level on progress. So it's really nice that we got to see that example, which really did seem in many ways like a best practice. But it certainly could be something that as we prepare for some other road trips, that we work on as background material for you all going into some of these other regions.
John?
Yeah, in terms of things on the horizon, I think, for example, the probably 15,000 hospital-acquired infections we have are a waste. They should be on the waste list. They're all preventable. Oregon's doing better than most states, but we still have folks who aren't doing well. I wonder if it's time for public health and the expertise and all they can bring to this to get more involved. Because, you know, I think we could do a better job. And that's the kind of waste or cost issue that would be hard for anybody to disagree with. So.
Yeah, I would add, so there's a healthcare requirement protections committee that does work, and I probably should have said at the beginning of the presentation, but you know, FAB is really focused on public health modernization, but that doesn't mean we stop doing the work that, you know, core public health is art. So no programs are going away because they're not mentioned here. So some of the core, you know, like healthcare licensing and some of the really core regulatory functions of the public health system are strong and maintaining. And but the FAB's work is really about advising sort of the policy direction of the future. And I think it's a great point, especially thinking about what some of the cost work will be happening in other health policy board priorities. But there are still some core, you know, surveying of facilities that public health pools, lodging, water, all of that great water quality, all of that great stuff is still really core to the public health system. Yeah.
And we do report hospital-acquired infections on our website. So, I mean, I've had friends that have like changed where they're getting their hip replaced based on the data that's been published.
Yeah, no, it's very powerful data. It's very powerful data, but getting it to the public is challenging.
Well, actually, one of the initiatives that we have, you know, I keep saying modernization is not just a program, you know, we'll get this much money, we're going to do this. It's about how we do our work. So one, just to this point, I think one of the initiatives that we are looking at now is, and this is our responsibility at the state level, you know, what is our contribution to the system? We are looking at how to make better visualization across all the data that we collect. So it's not just up there once a year in PDF format. And we've been working on this since January, and we have 16 priority data sets that we're hoping that will be much more interactive for the public, for people who are in community-based organizations, for people who are writing grants, and also to hold ourselves accountable for what's actually happening. So thank you for bringing that up, Dr. Stanton.
Thank you very much. That was very enlightening, so appreciate you doing that. All right, so ending on a high note, legislative update by Jeff Scroggin, Esquire.
When did that happen?
He doesn't even have a horse.
Good afternoon, Chairman Kelby, Vice Chair Banksburg, members of the Oregon Health Policy Board. My name is Jeff Scroggin. I'm here to provide a legislative update for you, and I'll just do this pretty briefly. In your packet, you have a Health Policy Analytics Division legislative update. This is tracks some of the bills from the Health Policy and Analytics Division priority standpoint. There's other bills that are also very, very important to OHA that may not be on this list, full disclosure. I'll review some of these bills with you. Briefly, you can click on any of the bills in this to go to the website, the Legislative Information System, and learn more about where this legislation is, what the bill actually means, any summaries by the legislative offices, and where different people may stand on the legislation. Before I dive into the couple bills I wanted to highlight for this, I wanted to share the coming deadlines for the legislative session, which is always good news. There's a deadline on the most coming deadline. The soonest deadline coming is May 10th. And this is a work session posting deadline. Bills have to be posted for a work session in order to move forward by the deadline on May 24th. It doesn't apply to some committees, some revenue rules or joint committees like the Joint Ways and Means committees. There's a very important revenue forecast that's coming out on May 15th. It's not a deadline, but it will really signal to the legislature what the budget forecast looks like and what next steps might be in budget development as the session comes to a close. And then on May 24th is that previous deadline I had mentioned where bills will need to have had a work session in order to move forward, except for some of the committees that don't follow that, that rule doesn't apply to, like the Joint Committees of Ways and Means, Revenue and Rules. Okay, so those are some of the deadlines. You can Google them as well if you want to review them. They're on the Oregon Legislative Information System website. The couple of bills I wanted to kind of lift out from the briefing for you are around House Bill 2267. House Bill 2267 is the agency CCO 2.0 bill, and really a direct reflection of the board's recommendations. If you'll recall, towards the end of the CCO 2.0 report and development process, we brought forward a few one-pagers for a couple of board meetings in a row that kind of identified where statutory changes would need to be made in order to enact the board's recommendations related to CCO 2.0, and this is the carrier for most of those components, including things like strengthening voices on CCO governing boards, and community advisory councils from OHP members and consumers, strengthening the health assessment, community health assessment, and community health improvement plan, strategy priority identification. This kind of goes back to how CHIP, and CHAWS all kind of go together, and making it clear that we really want shared priorities and strategies among hospitals and local public health authorities and CCOs, and we want them to be transparently available for the public to be able to review. There's an option here for a reinsurance program to continue that or build one up for CCOs. There's a tribal component to this bill to streamline the way that CCOs and tribes interact to improve healthcare. It includes CCO tribal liaisons and a tribal advisory council to advise CCOs and those tribal liaisons around things like the community health assessment, community health improvement plan, and to better resolve tribal issues with CCOs. There's a component for a one-time rate change to account for new membership as a result of the new contracts and new CCOs that may come to pass. And then lastly, there's a small provision to ensure that CCOs are not construed as small businesses, since they're not small businesses. The bill is moving along. It's in Ways and Means. We think that it'll meet the deadlines and move forward, and I'm happy to take any questions you may have around this legislation. I'm just going to move through this. Interrupt me if you have questions. The next one is the next one on the list. This one's SB 1041. This one is related to the board CCO 2.0 work as well. It kind of focuses on solvency, fiscal transparency for CCOs, and implements some tools so that we can have better transparency around fiscal situations for CCOs and ensure that they have solvency. And Pat's kind of an expert on this one, so I wanted to see if he had anything he wanted to add around it.
Yeah, this is probably causing the most friction with CCOs. Some small number of them are just flat not in favor of this, although I think we've got them talked out of actively opposing the bill. I think all of them are nervous about how this will be applied in a way that basically imports some features of the insurance code and applies them to the insurance functions of CCOs without treating them just like insurance companies, which is a fair point. We've had a couple of work group meetings, and I think we've got some amendment language taken care of, but this will be a pretty complex rulemaking that'll take quite some time between now and about November.
The next bill I'll touch on briefly is House Bill 2269. I don't want to go too far into this one. I'll preface by saying that this bill was a result of an established task force which gave OHA and other agencies in the government a charge of designing a program that helped fund the Oregon Health Plan. So this is one component of how we might have funded the Oregon Health Plan. It's about an employer spending requirement for large employers to contribute to their employees' health care. One option for employers to comply with the requirement would be contributing to a healthcare access fund, which would consider additional subsidies for Oregon's marketplace, as well as the Oregon Health Plan. Zeke actually wrote to us and asked us about this bill because it has a call out for the Oregon Health Policy Board. So I want give a little more background on that. One of the things this bill identifies as a potential role for the Oregon Health Policy Board would be to consider the rate of that charge to employers. The per worker hour spending threshold is what it's called. And what that might look like for the board is something like, the agency and other agencies and communities might make recommendations to the board, and the board would hold public meetings to discuss and validate the recommendation. It's worth noting that we don't think the bill is moving forward at this time, but no good idea goes dead forever, so it may return in future legislative sessions, and we'll keep you updated about it. The last bill I wanted to review briefly is Senate Bill 3063, commonly referred to as the vaccine exemption legislation. The board updated its vaccine policy at Oscar's suggestion a couple meetings ago, and David and Carla signed a brief letter to the legislature sharing that vaccine policy, and it's in the testimony file in the Oregon Legislative Information System for this bill if you want to go look it up. And I don't know if folks followed the news, but this was a hot one yesterday. It did get out of the House. I think it was 35-25. And we expect that it will be moving along briskly, potentially later this week in the Senate, and that the governor will sign it after it passes the Senate. That concludes my legislative update, pending any questions you may have. You're welcome to say any questions about any of the bills or legislative process anytime, and we'll get you an answer real quick. Thanks for your time.
John McConnell referenced 889, the cost bench bill. Is that moving forward?
It is. Great call out. Senate Bill 889, the blue bar on the Oregon Policy Board's priority area work plan timeline that Trilby shared is moving forward. We just submitted minor technical changes to that bill today to Legislative Council. We expect that it will be heard in time to meet the deadlines, and we'll move forward.
All right, thank you. Our next meeting is June 4th right here. Don't forget July 1st and 2nd for Yellowhawk. So please put that on your calendar because that date has changed from what we had previously. And more information will be sent out from staff. So meeting is...
Could I just ask on that day, will it be a late start on the 1st? I mean, we gonna need to drive there?
Drive time.
Okay, so there'll be drive time.
Yeah.
Okay.
We won't start in the morning, we'll start in the afternoon.
Meeting is adjourned.